Olá, nós começaremos em 5 minutos.
Hello, we are going to begin in 5 minutes.
Boa tarde. Boa tarde a
Good
todos.
afternoon. Good afternoon to you all who are watching us. My name is Lorena Chaves. I am a dietitian and consultant from the General Coordination of Food and Nutrition from the Department of Promotion of Health, from the Secretariat of Primary Attention to Health, from the Ministry of Health in Brazil. And with great happiness, we begin the first day of the second International Seminar of Food and Nutrition in the Primary Health in the coordination of food and nutrition from the Ministry of Health with the PAHO in Brazil. I thank the participation of you all who are listening to us, and I inform that this seminar is being broadcasted and translated simultaneously to 3 languages, Portuguese, English, and Spanish, and we are transmitting it, broadcasting it in our YouTube channel from PAHO. If you wish to make any comments, we ask that you use the chat from the Zoom platform. We wish that the debates done here during the seminar have great marks for the advancement for the universal coverage of the nutrition actions in health systems and represent important steps to exchange and reflect upon the challenges for the advancement for these actions of food and nutrition and primary care to health. Beginning our seminar, we are going to begin our opening conference. I invite the Secretary for Primary Healthcare from the Ministry of Health in Brazil, Rafael Câmara Medeiros Parente. Mr. Rafael, welcome. Thank you, Lorena. Good afternoon to you all. Although I did not receive the name, I'm going to talk about the people that I'm seeing here. I would like to salute my director, Juliana, from the Department for the Promotion of Health. I would also like to salute Giselle, the coordinator. And I'm also seeing Chris from CONASEMS. I'm going to salute you all. And also Dr. Maria Jose from CONAIS. And to salute all the managers, state managers, and other participants, which I'm seeing now. We have 533 people watching. So I would like to have a great event by opening here through the Ministry of Health in the person of our minister. The Ministry of Health has been supporting the investment in many strategies that aim to promote the adequate nutrition and health nutrition. Since the time I came here, we have been having a very strong action in this sense. For that, the federal government has done actions to promote and qualify the attention to nutrition, as well as this access to nutrition in all means. This is an important initiative in our management was the investment of almost 23 million reais in this nutrition issue that it possibilitated to have many municipalities receiving food and having care in this primary attention in all the country, and especially in these small cities. So another important initiative was the food guidance for children with less than 2 years old. This version talks about the food feeding children and recommendations about the feeding small children and complementary food and choosing good food. We also launched the first guide for the promotion of physical activity in the country for the Brazilian population, done by the greatest specialists from Brazil. We are also last week or 2 weeks ago, I went to Rio de Janeiro to launch the same guide in Braille, in the Brazilian Sign Language. There was the first document in this history of the Ministry of Health who has in this Braille scripture. We also went to Valença to launch a decree for health academias to have for other municipalities from Brazil to show the importance that this theme has for our management. This guide reinforces that the regular practice of physical activity followed up by a good nutrition aims to have a good to combat cancer diseases and other diseases from the body. Our minister, as a doctor that he is, we have a great obsession in this theme to promote health through health habits. That's why we are sure that we are going to be not only able to improve the population's health, but at the same time optimize the resources to promote health and diminish diseases. And then this is going to help us for the in order to not spend more money in taking care of diseases. So in the context of the COVID-19 pandemic, we also launched a decree for chronic diseases focusing in obesity, diabetes, and hypertension. This is a new thing, and it is important to remember that the primary attention to health is centered in the necessities of individuals who are centered in determined by health, and we are here in these essential resources and to promote health and rehabilitation of health also. The primary attention and the strengthening of the primary attention is a focus of our government. The secretariat created by our president, the Ministry of Health, and the current management, including we are going to launch alongside Juliana, the director, another decree, the important one, actually two decrees for the primary attention in Brazil, which is we're going to be able to see tomorrow morning. And we are going to do it alongside the minister. This will be at 10 a.m. Brasilia time here in the Ministry of Health. Just finalizing here, we have many teams and community agents beyond all the other professionals, health professionals that support these strategies. They answer for the coverage of 70% of the population, saying that it is increasing each time more with our new program for financing Previne Brazil, that last year we had for the 27 units of the federation to foment the managers in all Brazil. In this sense, the Ministry of Health foments the coordination of food and nutrition in the Department for Health Promotion in partnership with the PAHO that I salute now. I don't know who is representing PAHO now, but I would like to salute PAHO now. Alongside states and municipalities have been promoting the organization of programs and agendas from the Agenda for Food and Nutrition stimulated to the qualification of health professionals of APS, which is primary health care. So the second seminar is another strategy that aims to have a sharing of these actions and promote actions that can impact positively the health and nutrition of the population. Since I arrived here, I always said that one of our main actions that the Ministry of Health has with the government is to foment, to train the managers, mainly the municipalities that have difficulties. They're the poorest ones. It's our main issue to do this, main mission. So I hope that we can do another event that is hybrid or present one. I think that's important to have this contact that we have been doing in Brazil. So last week we had a presential an online, not an online event, a present event talking about the health of the teeth. And so I wish you a good event. I believe that all the directors and coordinators will give me feedback for what was done here, what we need to improve and act to in order to improve the food and nutrition of the Brazilian population. Thank you very much.
Muito obrigada, senhor Rafael.
Thank you, Mr. Rafael.
Agora, a
We
senhora
now
Geisa
invite
Pedro,
Ms. Elisa
coordenadora da
Pietro,
Biomedética,
coordinator from the technical
Inteligência
unit
à Saúde, Doenças
of
Crônicas Não
Health
Transmissíveis,
Determinations,
PAO,
Chronicle
da OBAS,
Non-Transmissible
OMS.
Chrome Diseases from
Senhora
PAHO
Elisa,
and
a
WHO.
palavra é sua.
Ms. Elisa, I give you the floor.
Muito obrigada, Lorena. Olá a
Thank you,
todos e
Lorena.
todas.
Hello to you all. Welcome. I would like to salute Mr. Rafael Câmara Medeiros from the Ministry of Health, Ms. Maria José Evangelista, which presents the National Council of Secretariats, Ms. Cristiane, President from the National Council of Municipal Health Secretariats, Ms. Juliana Rezende, Director from the Department for the Promotion of Health, and Ms. Gisele, the Coordinator of Food and Nutrition from the Ministry of Health in Brazil. I thank your presence from you all, especially to the representatives from countries, and our panelists, and all the managers, health professionals, researchers, and civil society that are participating in this second international seminar. It is a great satisfaction to be here, dialoguing with you about the technical and scientific evidences and this exchange of experiences that are national, international, of food and nutrition in the primary health care. We are more than 5,000 people registered. This is a great success. The many ways of bad nutrition, be it malnutrition, overweight, obesity, they have in the same country, they coexist in the same community, the same country, and they are even in the same family, possibly. They are interconnected. While hunger is still a great problem, overweight and obesity have been increasing rapidly in the world, mainly in countries of low and medium income. The charge of nutrition and the increase of these chronic diseases were severe, became more severe with the COVID-19, persisting in these economical and social barriers and sedentarism. The bad nutrition will take these risks, will be a risk factors related to the diseases in the world. The region of Americas has the greatest rates of overweight in the world. 62% of the adults, 73% of children and adolescents have a overweight or are obese. In Brazil, these rates are also high. More than 60% of adults are overweight or have obesity. We know that this sanitary challenge has many issues to be dealt with. We also know that we have many actors and institutions that act in this field of nutrition, food, and health. And this answer includes the strengthening of the organization of the health systems through the primary care healthcare, about the promotion, protection, and prevention, and rehabilitation of health in actions about in health and with characteristics about behavior, social behaviors, economical and environmental ones. The primary health care promotes and protects the health through public policies, evidences in all the sectors, and through the empowerment of the society. The pandemic highlighted how this is very important to be done. To improve the integration with the institutions in the health systems are necessary to have these good actions and human resources, good leadership, financing, and having resources and information and monitoring. To coordinate the efforts, like as an effective participation of countries, to reinvent all these these ways of malnutrition to amplify this. In 2016, the General Assembly of the UN promoted the decade to action on nutrition. So with the support of other partners, we have been doing things in order to improve nutrition from the population, including the regulation of the management resources, the actions for and the qualification of professionals who act in the primary health care, according to recommendation from the work plan for the Decade of Action for Nutrition. The first seminar of nutrition in APS, which was done in 2008 by the Ministry of Health in Brazil, contributed for these efforts, possibly making it able to identify potentialities for the construction of vaccines who are linked with the necessities of each population, respecting its culture and aiming to promote health and the health quality of the population. I am sure that the debates and discussions of the second seminar will make it to have a dialogue and reflection in order to support actions for being built in a modern and complete, and to help in these actions for food and nutrition in the organization of the primary health care in the national scope and international one. Without a doubt, this technical cooperation will make it possible for countries to reach good taxes, good rates, and to maintain in relation to this union guidelines and to make relevant actions in order to implement plans for nutrition and food, and in the plan for the action for the control of chronic diseases. We also contribute to the improvement of food in the populations. Thank you very much. Thank you very much, and please have a good seminar.
Muito obrigada,
Thank
senhora.
you very much, Mrs.
Agora
Elisa.
convido a senhora
And now I invite
Oliveira Evangelista,
Maria José, which is a representative of the National Council
Maria José,
of
muito bom que você
Health
conosco.
Secretary. Maria José, it's very good to have you here. Good afternoon, everybody. I would like to greet Dr. Rafael, with CAP Secretary, Dr. Elisa Pietro of OPAS, Parro, Dr. Cristina Pantaleão, Vice President of CONASEM. We are always together. Juliana and Gisele, we are always together fighting to have a primary care better here in this country, and all that are watching us in the internet. So I think that we have in SUS a guideline which is very big in about primary health care. And as said, I think that our biggest challenge is to take out these things from the paper and put into practice. We have this primary care model that's not adequate to the country, but was strongly made worse by the pandemic. We not are over it, but we're going to get over it. I would like to greet everybody that work with the food and nutrition, because everybody is very committed with the situation in the country. And I think in primary care, this challenge that I already mentioned, it's something that we have to put together all the questions um, alongside with food. We have a lot of things that are happening are good, but of course we have to make more efforts, like obesity, overweight. It's a problem when you see around. We see that, and in fact, with that model, it's very difficult, but together we will do this in a better way. Thank you very much, and I wish to everybody a great seminary.
Muito obrigada, senhora Maria José. Agora convidamos a senhora
Now we invite
vice-presidente do Conselho Nacional de Secretarias
Cristiane Pantaleão,
do CONASEM.
which is Vice President of CONASEM.
Bem-vinda. A palavra é
Madam Cristiane, welcome. The
Boa
stage is yours. Good afternoon, everybody. They are mentioned here. It's a satisfaction to start the years with this kind of events, having the health ministry participation, PAHO, and we realize that we need to work together because we have a big challenge. Us that are ahead of the defense of municipalities, we hear every time the challenges that the municipalities are having in primary care. So we know that 85% of this primary care, it's the problem that we have. You can imagine the pandemic. Last year, we started to work prevention and promotion in health, not only for COVID, but the other factors that are alongside with our care. But unfortunately, in the beginning of the year was very difficult with the primary care where we have an increase of COVID cases. So beyond the case post-COVID were worse because last year not everyone was vaccinated. So we have the side effects of the patients. We have the chronicle patients that are not health in treatment, and we have the obesity things that are related to that, mainly these moments of pandemic. And we have in January, thanks to the vaccine, lighter cases, but the number was something very high when we had some amount, but in this January, the major of the municipality have 4 times more than the worst moments of the pandemic. So you can imagine the amount of people that look for the primary care. And we know that sometimes expectant women are not looking for the primary care because of patients with cold, diabetic people, hypertensive, people with obesity, and all the people that are suffering the consequences that don't have this primary care attention to these people. So we have to be together here, thinking about strategies to strengthen this prevention and promotion of health related to nutrition, but we cannot do that without support. So we have to recognize the role of Rafael, which is ahead of the secretary, and reinforce the resource deals. And we hope that this partnership don't miss. And we are in a moment to rethink our actions and primary care, as I said, put in practical ways, because we can do that without resources and without the support and with supports of PAHO that we have to count on. So I'd like to congratulate for these events and to say that municipalities are here at your disposition, and we know that we have work to do to face that, and we know because we have experience now, and mainly in the food and nutrition area, or the workforce of SUS, the national healthcare, we can make quality work with efficiency, and for sure we only do that because we are together. So I wish you all success and that we can leave this event with a lot of proposals that we're going to need. But we have to live here as a multi-situation team, because we're not going to do this alone, without support, without economic area. But I'm sure that we have a goodwill that with everybody that is involved. Thank you very much. Have a good
Muito
seminary.
obrigada, senhora Cristiane.
Thank you very much, Cristiane.
Convido a senhora Juliana
So I
Rezende,
invite
diretora do Departamento
Miss
de Promoção da
Juliana,
Saúde do Ministério da
with
Saúde, para
the
receber
director
a
of
leitura da primeira
the
carta de Brasília, escrita na ocasião do primeiro seminário
the reading of the
internacional
first letter
na atenção
was
primária,
written in the first
realizada em
International
2008.
Seminar of Nutrition in
Juliana.
2008.
Olá, boa
Welcome,
tarde.
Juliana.
Muito bom
Hello,
estar aqui
good
presente
afternoon,
e agradecer
everyone.
também
I
a
would like to
participação de
thank
todos aí que estão na
uh,
mesa de
the
abertura, que estão
participation
aqui
of
conosco, o
every
Rafael,
person who
que
is in this table.
apoia e organiza
Rafael,
e
the
leva a agenda de saúde
secretary,
e
which
nutrição para o
support
ministro, para o
and
presidente, para que a gente
provides.
continue fortalecendo as ações
So I
de
hope we
promoção da
can
alimentação e um
strengthen
hábito saudável. Eu vou fazer a leitura da
all
carta,
the
que foi no
area. I'm
primeiro
going to
seminário
read the
internacional de
letter,
nutrição da atenção
which was in the
primária,
first
que aconteceu em
seminary
Brasília no dia
that
9,
happened in
no dia 9 e 10
Brasilia
de novembro de 2008.
in
Considerando
2008,
a
9/11.
alimentação adequada como um direito humano
Considering adequate
fundamental por
nutrition as a
princípio
fundamental
universal
human right
e
and respect
considerando o
for
compromisso
life
com
and
reduzir
health,
as
the
desigualdades
commitment
sociais,
to
econômicas e de
reduce
saúde que devem permear
social, economic, and
todas as
health
implementadas
inequalities that
ações
should
dos países.
permeate all the public
Considerando o
policy
dinamismo
implemented
do
in
processo de saúde e
different
doença
countries.
e o
The dynamism
intensificadamente
of health
transição
disease process and the
epidemiológica e
intense
nutricional dos
process of
países. Considerando o
epidemiological and
impacto
nutrition
de
transition
doenças
of
pelo
the
qual o
countries,
país passa
the
ou vai
double
se
burden of the
desenvolvendo.
disease the developing
Considerando a
countries go
importância da
through,
atenção
the
primária de
importance
saúde
of
para enfrentamento da
primary health care to cope
universalizada,
with this
equânime,
scenario,
regionalizada e
universalized,
potencializada.
equitable,
Considerando a
regionalized, and with
consistência com a
social
Agenda Única de
control,
Nutrição para a
the
Promoção da
recognition
Saúde
of
das
unique
Pessoas
nutrition
e do
agenda for
Desenvolvimento
promotes
Social e
people's
Econômico dos
health and the
países.
social and economic
Considerando
development
a
of the
urgência de
country.
sensibilizar
The
gestores
urgency
e
of
demais tomadores de
sensitizing
decisão
managers and other
sobre o papel
decision makers
estratégico
about
da
the
nutrição no
strategic role of
funcionamento efetivo
nutrition
para a
and as an
melhoria das condições de
effect
saúde da
tool
população
to improve the
e
health
ainda no
conditions of
contexto
the
da realização
population, and
do presente
also in
seminário
the
que reuniu
context of
profissionais
the
advindos das
seminar
diversas
which brought
academias
together
de
professional
planejamento e gestão pública
professionals
de
from
governo da
academic
Bolívia e
institutions,
Equador,
planning and public
Costa
management, the
Rica,
governments
Espanha,
of Bolivia,
Peru,
Canada,
Reino Unido,
Chile, Costa
Uruguai,
Rica,
de
Cuba,
organizações não
Spain, Mexico, the
governamentais e
United
organismos
Kingdom, and
internacionais como a
Uruguay,
OMS e a OPAS,
and
bem
other
como ainda de
organizations
atores,
like
gestores e
WHO and
instituições que atuam
PAHO.
no campo da
It's
alimentação, nutrição
recommended
e
to
saúde.
all actors
Primeiro,
and institutions
coordenar
to
e
work in the field
intensificar
of food,
esforços para
nutrition, and health.
estabelecer
First,
a prioridade
coordination and intensify
ações de
effort to
nutrição nos
strengthen
âmbitos de
prioritize
atenção
nutrition
primária,
actions with
com ênfase
primary
no
care with
planejamento
emphasis on
situacional e territorial, na
situational
formação de
and
vínculos e
territorial
organização
planning,
de rede.
building, and
Segundo,
humanization of
fortalecer
care.
processos de trabalho
Second,
eficazes
strengthen
de
plural and
discussão,
collective work
planejamento,
processes of
implementação e
planning,
avaliação
implementation,
para a
and
consolidação
evaluation
de
with
uma agenda
social
única de
control of a
nutrição
single nutrition
com
agenda
base no
based
ciclo vital.
on the life
Terceiro, incorporar com
cycle.
agilidade
To
novas evidências
incorporate
científicas
with
na
agility
implementação
new
e no
scientific evidence in the
redimensionamento de
implementation
políticas
and
públicas.
redirection of policy and
Quarto,
actions.
garantir a inclusão
Fourth,
de conteúdos
ensure
que
the
visem
inclusion of
experimentação e
contents
extensão
and
da
the
atenção
experience
primária de
in food and
saúde na
nutrition,
formação dos
primary care, and the
profissionais,
training of
bem como
professional as
desenvolver
well
e
as
intensificar
develop,
aperfeiçoar
intensify, and
mecanismos
improve
de avaliação
mechanisms of
permanente de
permanent
desempenho.
formation in this field.
Quinto, dar
Fifth,
visibilidade e
provide
disponibilidade às lições
visibility
aprendidas,
into experience and
viabilizando
lessons
a
learned,
troca de
creating
experiências de
mechanisms for
planejamento e
exchange and
gestão
experience
de
of planning
políticas
and
públicas
management
e
of food and
nutrição
nutrition
e de
policies
formações de recursos
and training of
humanos.
human resources. 60.
Implementar ações
Implement
regulatórias que
regulatory
favoreçam a
action that
alfabetização
favor nutritional
nutricional
education
e
actions and
facilite as hábitos
facilitate
saudáveis pela
health choice by the
população.
population, including
7. Incorporar
A.
os princípios e as
Seven,
abordagens da
incorporate the
comunicação social
principle and
nas
approaches of
práticas e
social
estratégias de
communication, the
educação alimentar
practice
e
strategies
nutricional,
of food
com
and
respeito à
nutrition
vida
education with
familiar e à
respect to
valorização de
food,
hábitos
culture, and the
afetivos de
valorization
alimentação.
of effective
8.
habits of health
Garantir o
eating.
monitoramento e
8,
avaliação
ensure the
das ações
monitoring and
desenvolvidas, bem
evaluation
como
of
o
the actions
desdobramento dos
developed
trabalhos
as well as the use of their
aperfeiçoamento,
results in the
redirecionamento de
improvement and
políticas
or
públicas.
redirection of
9.
policy and program.
Formar rede entre
9,
países
form a
para
network
fortalecimento
between
e qualificação
countries
da nutrição
for the
nas
strengthening and
localidades.
qualification of
10.
nutrition and primary health care.
Intensificar as
10.
parcerias para
Intensify
participar das
partnerships and
responsabilidades
agree
que
with
estabelecidas pelas
responsibilities between
academias
management
e
bodies,
organismos
academia,
internacionais
and
para a
international
qualificação,
organization for the
planejamento,
qualification of
implementação
planning,
e avaliação de ações
implementation, and
alimentares,
evaluation of food and nutrition
reforçando
action,
capacidades e
strengthening local
potencialidades
capacities
locais.
and potentialities.
Muito obrigada, Juliana,
Thank you
pela
very
sua
much,
leitura dessas
Juliana,
recomendações
for your
que foram
reading
apresentadas no primeiro
and of these
seminário.
recommendations. that were brought on the first seminary, and it's going to help us to reflect, to make the second ladder which will be the product of the seminary. And now to bring orientation about the making and the building of the second ladder during this event, I invite Ms. Gisele Portolin with the General Coordination of the Health Ministry. Gisele, the stage is yours. Hello, good afternoon to everybody that are watching us. Our secretary, CONAS and CONASEM, which are partners. And I can see the political happening. We have more than 5,000 municipalities, so we have a big challenge to implement this public policy. Juliana read the letter of 2008, and we have all these challenges in 2022, and we would like to debate the challenges of this primary healthcare agenda, and we'd like to invite everybody to help us to write the second letters in Brazil. So how that's going to be? I'm going to share the guidelines. So how that's going to work? The question is, what do you think is necessary to make this nutrition agenda a priority in the primary healthcare? As you see, at the end of the day, today we're going to disclose a study that was made in Brazil that we have 35 recommendations what the manager should do to advance in this agenda. So we'd like to discuss with all of you and interact so you can say what you think that we need to do to make this agenda a priority in the primary healthcare. So considering these goals, sustainable goals, like said, food as a right, I would like to disclose that last year we got 20 years of this program. We have this public health notebook that make an evaluation of these 20 years. So I invite you to access the website and interact with us and send you your suggestion to make this letter. This link is going to be open until Wednesday at 7 p.m. So in Thursday, we can make this consolidation and read the second letter with the debates that are going to be made. So I'd like to disclosure that in the website nutriçãoaps.com.br, you can share your experience. So you can tell us about your experience or about our Congress and your experience, so you can contribute to implement the public policy and to support this debate. So I wish you all a good debate and a good event. Thank you very much for your orientation, Gisele. So in the sequence, we're going to initiate the Magnan conference with Dr. Peter Phillips Von, which is a doctor, a researcher, and the president of research and facilities in health of the biometry and epidemiology of the public school, Peter Kofter of the Munich University. Dr. Peter is going to talk about, and we remember that the audience could leave your comments on the Windows chat. So we are going to have 30 minutes. Be welcome. The stage is yours.
Thank you very much for this kind introduction.
Thank you.
So you can hear me well. It is a pleasure for me to be here. I'm very sorry that I'm not able to talk in Portuguese to you. I've been able to spend some time doing my training in Latin America. It was only in Spanish-speaking countries and not in Brazil. So that's why I have to stick to English. It's really a pleasure and an honor for me to be part of this conference. I will now share my screen for my presentation. So now you should be able to see my presentation. I would like to talk during the next 15 to 20 minutes about food and nutrition actions in primary health care. I would like to start with a few words on the background, the global nutrition transition and the need for action on nutrition, which was already stressed by the previous talkers. Then I would like to present a framework of action for nutrition in primary care. And then I'm looking forward to discuss these issues with all of you. I would like to present ideas which I've developed together with a number of co-authors in an article which was published in 2020 in the Bulletin of the World Health Organization entitled Primary Healthcare and Nutrition. And I would like to thank my co-authors with whom I developed these ideas, which will be the basis of my presentation. I would like to start with the following two graphs. The way we feed ourselves has been transformed radically during the past 60 years. Here on the left side, we see food availability per capita, which is a quite good proxy for actual food intake in grams per day per person. These are global averages in 1960 and 2013 in comparison. We see that today we all globally eat much more fat than we used to eat, more protein, more sugar, much more meat, almost double the amount of meat that was eaten in 1960. Also more fruits and vegetables, which is of course a very welcome development, also more cereals. Here on the left side, we see the consumption of ultra-processed foods in percentage of total energy intake. We see that this percentage has risen. It's rising worldwide in almost all countries from which we have data. And in many high-income countries in North America and in Europe, the share of ultra-processed foods in the total energy intake is already more than 50%. And also in countries like Brazil, it is rising rapidly. That is, today we eat more than we used to eat. In particular, we eat more ultra-processed foods with a high content of fat, sugar, and salt. This development, the global nutrition transition, the transformation in the way we feed ourselves, has of course had very important consequences for human health. Here we see the number of children living with obesity worldwide from 1975 to 2013. It has risen a lot. This is actually really an exponential growth. And also the prevalence of obesity among children has risen a lot, about sevenfold from 1% in 1975 to 7% in 2015. Among adults too, the prevalence of obesity is rising worldwide in all regions of the world. And actually there's not a single country in the whole world which has managed to stop or to reverse this trend towards higher rates, higher prevalences of obesity. So this is really a global challenge affecting all countries worldwide. This is also reflected in the rise in the number of adults living with diabetes mellitus, which is of course a very important diet-related disease. It's a very complex disease, also very costly to the health sector, which binds many resources in the healthcare sector. The number of adults living with diabetes mellitus was about 100 million in 1980. and it has risen fivefold since then. Today, about 500 million people worldwide, adults, have diabetes mellitus. And also the prevalence, the share of people in the general population who have diabetes mellitus has also increased, has doubled about from 5.6% to 8.5%. However, this development, the global nutrition transition, has not only consequences for human health, but also affects many other areas, many other aspects of human existence. And it is not just overnutrition and obesity which is a problem, but also other aspects of non-adequate nutrition persist in many countries worldwide. For example, more than 800 million people worldwide are undernourished. More than 2 billion people have micronutrient deficiencies, and as already mentioned, a very large number have overweight and obesity. In all its forms, malnutrition, including undernourishment, micronutrient deficiencies, overnutrition, obesity, is responsible for about 20% of all premature deaths worldwide, and about 20% of the global burden of disease. Besides these direct links between health and nutrition, there are also important indirect links. For example, the use of antibiotics in agriculture contributes to the development of antibiotic resistance, which also threatens human health. Besides, most infectious diseases which afflict humankind have arisen as zoonosis, that is, they originate in animals used as sources of food. Examples for such zoonosis are HIV/AIDS, Ebola, influenza, tuberculosis, most helminth infections, sleeping sickness, salmonellosis, COVID-19. All these are zoonoses which have arisen in the food system. So nutrition, or the global food system, is of tremendous importance for our health, but it is also relevant for other aspects of the human condition on Earth. For example, it has many social implications, many economic implications, and also implications for what is called here the biological system, that is the integrity of the natural systems. Just a quick spotlight on some of these repercussions of the global food system. There are, for example, many important links between the global food system and environmental sustainability. About a quarter to 1/3 of all greenhouse gas emissions worldwide are caused by the food system. Agriculture is the most important driver behind many processes of global environmental change, including biodiversity and habitat loss, deforestation, desertification, and land degradation. At the same time, agriculture depends more strongly on the natural environment than most other human activities. This implies that the same processes of global environmental change to which the global food system strongly contributes, they also endanger the global food supply. Besides, the global food system is also very important for human livelihoods, for the social economic aspects of human life. Globally, about 1 billion people work in agriculture, and about 2 billion people depend on agriculture for their livelihoods, considering also the family members and dependents. So we have seen nutrition is really of extreme relevance for our health, but also for human well-being in general. And the global nutrition transition, the way we feed ourselves, has changed during the past decades, comes with tremendous challenges. And this leads us to the question what primary care can contribute to meeting these challenges of the global food system. And here I would like to present a framework for action on food and nutrition in primary care, based on the article which I've mentioned at the beginning of my presentation. In this article, we distinguish 4 important areas of action for nutrition in primary healthcare, labeled as follows. Firstly, bridging narratives between discourses on nutrition in primary care. I will explain shortly what I mean with these words. Then second, primary healthcare providers as actors for multi-sectoral action on nutrition, empowering communities and individuals to take action for better nutrition, and integrating nutrition interventions into primary healthcare delivery. So regarding this first point, bridging narratives between discourses on nutrition and primary care. What do I mean with this? When we talk about nutrition, there are two perspectives which are very common. The first perspective could be called the biomedical perspective, which is focused on individual food intake and the effects of individual food intake on neurobiological processes in our brain, metabolic processes in our body, so in general on biological processes within our own body, within the body of individuals. So this is a biomedical perspective. Then there's a food systems perspective, which is much broader and which looks at so many different complex factors which influence food intake, like the economic system, the social system, the political system, the health system, the biological system. So these two perspectives, they dominate the scientific and policy discourse on nutrition. And they are both very valuable and they provide very important insights. However, they can be quite technical, quite abstract, and also far removed from the daily experiences of individuals in local communities. Primary care, by contrast, is focused very much on the perspectives, the needs, the daily experiences of individuals in local communities, and also on individual human rights. And I think it is very important that in the way we think and talk about nutrition, that we bridge the gap between these different perspectives. Because obviously it is the biomedical perspective and the food systems perspective, they're very important, and we need to take into account the insights provided by these perspectives. But to create a compelling narrative which inspires people and which is meaningful to people, and not just to scientists and to professionals and technicians, but also to the general population, to policymakers, to a broad range of actors. To create such a compelling narrative, we have to consider the perspectives, the needs of individuals and of communities and of their daily experiences. And this is something which primary healthcare professionals, primary healthcare providers can contribute. They can make visible that behind every number there's a human story. That's why I think that primary health professionals are not only important actors as practitioners in the area of nutrition, but also as discussants and as individuals, as professionals who contribute to the global debate on nutrition and health. So the second area is primary healthcare providers as actors for multi-sectoral action on nutrition. Improving nutrition requires multi-sectoral, multi-level action. And primary healthcare providers, like for example, nutritionists, nurses, doctors, among others, they can support such action in a number of different roles. For example, they can support such action in the role as experts who work for government or who advise government, also civil society groups, business actors. All these organizations, they need professional technical expertise, and primary healthcare providers can provide this expertise and also knowledge on the needs and the perspectives of local communities. They can also contribute to such action in their role as mediators between patients and communities on the one hand, and government and other social groups on the other hand, as they are close to patients and local communities and are well aware of their needs. And they can also have a role to play as advocates for policy action. Because to meet the challenges of the global food system, policy action is needed. There's a broad range of policy measures available for policymakers who want to support and promote healthy and sustainable diets. One way to classify these different policy measures is the so-called Nourishing Framework, which was developed by the World Cancer Research Fund International, and which distinguishes 10 areas of action. The first one is nutritional labeling. The second one is quality standards or nutrition standards for school and workplace cafeterias, and in general for canteens, for cafeterias and public institutions. And price changes through taxes and subsidies. There's policies that affect the prices of different foods and beverages. Regulation of food marketing, reformulation of processed foods, which is also influenced by government policies, retail and food service sector interventions, so-called systemic interventions. These are policy measures in other policy areas, like, for example, trade or social policy, which also influence nutrition. It's not just about food and nutrition policy, but also about policies in other areas which have indirect influence on nutrition. Awareness-raising campaigns among the general population, dietary counseling in the health sector, and nutrition education in educational settings. So all these policies can be implemented on different levels. Some of them can be implemented on an international level, many of them on a national level or a regional level, and many also on a local level. And in particular, with regard to local policy action, primary healthcare professionals have an particularly important role to play, as they are often rooted in local communities and have unique knowledge of the local epidemiological and health and nutrition situation. And regarding local food policies, I would like to quickly present an initiative in this area, the so-called Milan Urban Food Policy Pact, which is an alliance of more than 200 cities worldwide, including also 6 cities from Brazil. Here on this map, we see that these 200 cities are really distributed around the world, and also many here in Latin America, including Brazil. This pact was initiated in 2015 by a meeting of mayors in Milan, Italy. That's why it's called Milan Urban Food Policy Pact. And the aim is to support the promotion of healthy, sustainable, and socially inclusive food systems, which should of course also be economically sustainable through local policy action, through action of cities. The approach is to promote networking and exchange of best practices among cities and local authorities, local government authorities. As part of this Milan Urban Food Policy Pact, a so-called Urban Food Policy Framework for Action has been developed, which includes a number of measures. For example, just to give you an idea, measures to make sure that nutritious, affordable food is offered in public institutions like schools, kindergartens, hospitals, recreational facilities, canteens of government offices. Support for offerings of nutritious, locally produced foods in retail settings, for example, by supporting farmers markets or direct procurement from local farms to, for example, public institutions. Regulation of marketing for unhealthy foods in public settings and facilities. Support for initiatives that promote social cohesion and communality in the production and consumption of food, for example, community gardens or community kitchens. And also initiatives to reduce food waste, for example, also food sharing. So the third area where primary healthcare can contribute to better nutrition is through empowering communities and individuals to take action for better nutrition. What do I mean with this? Action on nutrition can only be successful and sustainable when it's based on broad support from local communities and the population at large. So it has always to be participatory. We have to population, local communities have to be included, and the views have to be taken into account. And community organizations and also individuals acting as so-called change agents can be very important advocates for nutrition action. And primary healthcare providers can empower communities and individuals. They can enable the population to be active in this area, to take on this role by, for example, or most importantly, by providing the population with nutrition education, nutrition skills, and by raising also the awareness of the broader determinants of nutrition and health, which of course go beyond just individual factors. And in most countries, primary health professionals are the most important actors in providing nutrition education, nutrition skills. So this is really a key role to be played by primary healthcare professionals. The fourth area is integrating nutrition interventions into primary healthcare delivery. Primary healthcare providers, in many countries, at the forefront of delivering nutrition-related preventive, curative, and rehabilitative interventions, which include, for example, counseling on nutrition, in particular during critical phases of the life course, like early childhood or pregnancy, individual and group-based nutrition education, as I've already mentioned, diagnosis and treatment of malnutrition-related disorders, including anemia, micronutrient deficiencies, stunting and wasting among children, frailty among the elderly, diagnosis and treatment of diet-related disorders, including obesity and diabetes mellitus, and promotion of breastfeeding. So these are all critical nutrition interventions. Of course, it depends on the local context, which of them are of particular relevance, but most of them are in general delivered in primary healthcare settings. So to recap, these have been the 4 areas of action on nutrition in primary healthcare, which I have highlighted. The first was bridging narratives between discourses on nutrition in primary care, contributing this view, this perspective, this focus on individual experiences. The second was primary healthcare providers as actors for multi-sectoral action on nutrition. The third was empowering communities and individuals to take action. And the fourth was to integrate nutrition interventions to primary healthcare delivery. For all these areas of action, there are, of course, also examples from Brazil and from other countries in Latin America. And I think the world has a lot to learn from Brazil and also other countries in Latin America regarding these areas of action. That's why I'm also looking very much forward to the presentations of which will follow, and also the discussion. So thank you very much, and I'm also looking forward, of course, to your questions.
Muito obrigada, Dr. Peter, pela excelente explanação.
Thank you very much, Dr. Peter, for your discourse, but I invite Mrs. Maria José, Mrs. Cristiane to contribute in this reflection how advancing this agenda in the IPS. Each one of you have 10 minutes, and we start with Ms. Maria José, please. Thank you very much, Lorena. First, I would like to congratulate Dr. Peter for this excellent presentation. I already had the article that Giselle sent me, and it was an excellent presentation. As we are in an international audience, I will explain my 10 minutes in 3 parts. So first I will explain what CONAS is, my department, that we have 27 secretaries with 27 states and the federal district. CONAS was created in 1982, so we have 40 years, and it was created to strengthen the states because we have a big country. So we have like a local state with the size of Portugal, and we have another big states, and it's very unequal. Um, Economic issues, social issues. So that's why was created by Dr. Jatene, was a famous doctor here in Brazil, and he created CONAS. So we have some things that CONAS has to do. He have to support technical, the secretary, the experience exchange, and to seek for corporations. That's the goal of CONAIS, which represent the states. Chris is with us today. She represents the municipalities. Brazil is a big country, so we have almost 214 million people. We have 5,000, more than 5,000 municipalities, and we are divided in health regions. We have 117 macro regions and another smaller. So the idea is to every region will be self-sufficient, at least the majority, to attend the necessity of population. So all municipalities are responsible for primary care. So in this macro region, everybody has a primary care, but the hospitals, we have to be in the region, but every population have to be available access. So we have a three spread parted, and the state is represented by CONAS, and all of these are discussed in city with the commission of management that we meet every month to treat of these actions that are related to the national health system. So what refers to primary health care, we have when Dr. Pitt congratulates Brazil, sometimes we speak about ourselves, but when we go abroad, we see that we're not that bad. So we have almost 50,000 teams of family health, and that's a differential in Brazil, because in the other country we see the doctor as the main participants of the team, but here we have a multifunctional team that works in a lot of areas. So we have teams that work with primary health care that didn't work with family because we have a lot of diversity. We have an oral team that work with oral health. Sometimes people came to make this oral health care. We have teams that support the family health support teams. There are more than 5,000 teams. We have teams that work outside in the streets with homeless people at the big cities. So the system has it to support a homeless population. We have people that work in prisons. We have states that have indigenous people. So we have 304 teams that are specifically for the indigenous people, and more than 800 to home attention, type 1 and type 2. So we have, of course, it's a big country, but we have a good structure and framework of the primary care. Our program is just the model, because we divide in primary care, hospitals, and ambulatory. So we have these networks where another countries call integrated systems. We have a lot of guidelines. We have an ordinance that treats about this network. We have another law that guideline how it's organized in regions and macro regions. In our constitution, we have written that health is a right for everyone. So we have a good guideline in theory to guideline this system organization, but specifically about our theme, which is food and nutrition, I would like to highlight some points mentioned by Dr. Peter. We have a policy here in Brazil that's have been doing since 1989. The first one was in 1996 that's being been doing when Brazil institutes a program what is very fruitful of the communitary agents in 1981. We had this program was we have a very malnutrition trouble problem with children. So we started to organize this work since 1991. That's why we related this evolution, how the nutrition was developed here in Brazil. So the access to food, of course, it's better now, but it's the quality that is the problem. So how the primary healthcare can deal with that? Chris said that the sectorial issue. So it's not only the health sector that is responsible for that. We have to talk about agriculture. We have to discuss
environment issue, education, and also the economic part. Now in the pandemic, where the population of the entire world impoverished itself, and here too, so the access to food increases, but the quality is bad, and people, although they do not have resources, eat everything, anything. So when they eat anything, and then this goes the carbs and everything, so we have a population that is obese, and which is a very serious issue here in our country. And you talk about the perspectives, local perspectives for the necessity of individuals. So a country from our size, where you eat in the South Asian is very different from what you eat in the North region. So you need to consider this, the issue, the cultural issue, and the food that are there available in the local level, and the importance of the health professionals and primary attention. This debate, the self-care, supported self-care, the lettering, education of the population that does not have studies, and as a health professional, mainly not only as a doctor, nurse, but all the professionals of this multi-professional team to give the support. How can a person take care of its own food, nutrition, but also supported by their professionals? This is a great challenge. And I think that this fact that our primary attention is organized in such a way, it contributes a lot so that in fact we can give this to the population. But as I said before, the greatest challenge is this one. In a country that is very big, the situation of the pandemics makes everything more severe, and now we have sanitary crisis, political crisis, economical crisis, social crisis, and how, like Chris said, this is very logical, this is very difficult, but we also have one potential, which is the fact that this tripartite system that we are very strong, our professionals are very strong, they want to fight, they study, the managers are concerned about this issue of permanent education, because we cannot deal with this if we do not have the permanent education. I think I overstepped my time, right? But I would like to congratulate for your excellent presentation, and this was my contributions. I'm sorry for passing my time.
Tudo bem, Maria José, muito obrigada pela sua
Fine, Maria Jose, it's fine. Your contributions are very great. Now, Cristiane, please. Well, hearing Maria Jose speaking, I'm like, yeah, it's true, it's true. Yeah, we that work together, it's very nice to see how we are very well interacted. Conas, Conascems, we speak the same language, and this is very good because this is the idea. I would like to congratulate Peter for his speech, which was very important, the data that you shared. And this is it. I bring a little bit about the reality, like Ms. Maria said, how the Conasems represents the municipalities of the country. Imagine in a country like Brazil, with the diversity that we have to deal with, food and nutrition, it is very different. We dealing with food and nutrition within my city, which I'm here as a manager, Ivaiporã, which is 30,000 inhabitants in a neighborhood is different from the others. So what I orient for a population is different from what I orient for another population. And about this territory, neighborhood, imagine this in Brazil with the diversity, the cultural diversity, economical diversity of access, climate also. So this is really when we talk, we always work like Ms. Maria, as a tripartite level, Ministry of Health, CONAS, and CONASEMS, we always battle in the sense of let's work in a ascending way. This is the first thing. Never we're going to determine a policy and orient what each municipality of this country has to do to work the issue of prevention and promotion in health related to nutrition and food. So I think that this is the first issue, to understand and respect and know each territory. So each municipality needs to discover how to work with its population, what are the concerns related to the food and nutrition that each territory has. So what do I have as a possibility within my territory, both in issue of teams from primary attention in relation to the team, intersectorial team, that I can be thinking about strategies alongside the participation of the community to work with the issue of food and nutrition. So we are not going to be able to develop guides and manuals, orientation manuals that are sole ones for the entire country. And this is very difficult to be done. I think this is what we're trying to foment each time. Also, when we are going to develop any policy, any manual, any guide, we need to develop something in the manager, in the municipality, the health professionals, alongside the community. How to know each other, how within this possibility that I have, how to think about safe health, food, nutrition, how to prevent and promote health with the cultural reality, with the economic reality that I have here. So this is the first thing to try to look to develop this in our municipalities. So as like Conasems has been trying to work, the multi-professional team each time is more present within the daily routine of primary attention. So in 2017, when we talked about that we are not trying to end with NASP. When they did the review of the decree from the basic care policy, when we put the multi-professional team as the one that belongs to the primary attention, it is with the focus to say that many municipalities implanted NASP as a service that is outside of it. Now the primary attention will put the version to NASP, and this is what you're going to say. No, the primary attention, primary care is not like that. The obese person is every day there. The child that is in malnutrition is every day there in the unit. So it's there that the dietitian needs to be. It is with the team that takes care of this person every day, which is the dietitian that needs to work with. This is the dietitian with this team that needs to sit with the school and the kindergarten of the place and think about strategies to work with that community according to the reality and necessity of health for that community. Is it in the dietitian, the doctor, the community agent? Alongside the dietitian of education, that needs to think alongside the social part, which strategies we're going to implement in order to stimulate the economic development of their families, those families that have issues to have good nutrition because they do not have enough money to do that. So how to take these professionals and work in a joint way, intersectorial way to solve the health problems and nutrition, food, and promote and be able to do the prevention of the diseases for that territory. This is what is our challenge. And this is this team that needs to work with the mayor in order to develop strategies that also stimulate the state government and federal one to seek to support strategies and bring strategies to support this through this ascending issue with research. And this is what needs to be done so that what we hope needs to leave the paper, let's say, because what we write is very pretty, but this is not developed because it's not the reality, it's not part of the routine and the day-to-day basis of the team. Most of the time when the person reads a manual what they had to do, they do not see themselves there because this is not the reality in which they live in. That's why strategies need to be ascending ones. And without saying that, we also need to understand and respect each state, each reality. We know that there are states that do not have even pharmacies in those cities. I know many states which do not have even pharmacies. Dietitians is a dream. This is a luxury. So what we notice is that many times we need to work with the strategy to nutritional support and regional support that is unfortunate we do not have always. That's why the multi-professional team to help and support the primary care people to solve these problems, but they can also have this nutritional and regional support organized to give this support to the primary attention team of municipalities. And this is another thing that we also need to do, and how to finance a dietitian that meets 5 municipalities. So how do we develop strategies that support the regional situation? This is what Brazil needs with the diversity that they have. We have many situations in the Amazon region that the access will be only through telecare. So how can we strengthen this type of care? How can we put this being able to put it in our routine to give this possibility to for the people to have access to it? So this is our challenge, what we have close to us and which maybe would help directly for us to be able to take from the paper, let's say, what we need in relation to improve food and nutrition in our country. And CONAZER is beyond that, has been developing strategies, formation strategies. Now we are doing a course for the municipal management. So all the managers, we put a course for being a manager for all the managers in Brazil. We have more than 15,000 people doing this course. In this course, we talk and reinforce about the importance of how to organize primary care, seeking for the prevention and promotion of health, and food and nutrition is inside this discussion. So Canasians has been working with this issue of permanent education. We're going to begin now with a work. Sorry, let's finish your speech, okay? Okay, I'm gonna finish. So the issue of community agents, and then we're going to work now with the information alongside the Ministry of Health and to try to foment the issue of strengthening of primary attention and the use AppDoc, which we are proud to show that SUS we do it, unified health system, but we also have a lot of great results in relation to the stimulus of a food and healthy food and nutrition. This is what I'm sorry for having surpassed my time, but we are motivated to speak with this discussion. Thank you, Cristiane, for your contributions. They were very valuable. Many comments here in the chat. And now I would like to pass to the chat where we had many comments and questions. Among them, I'm going to make first one for Dr. Peter. I'm going to make 3 questions for him, and then I'm going to make them one by one, and then you answer later, okay? So the first one is, in relation to the 4 feed nutrition areas in the APS, the healthcare, the one that you said was the empowering of communities. So in your opinion, this empowering can be incentivized in which way? For example, communication, broadcasting, leadership. This is for the first question. The second one, good afternoon. Can we do nutritional education and promote of a healthy food in the primary attention care attention without dietitians? And the third one, I would like to ask how do they know the construction of the assistance, interprofessional assistance in the process of working in the primary health care within nutrition, within this medical hegemonic model? And I'm going to ask Dr. Peter to answer these three questions, and maybe if there is time, you're going to open for more questions. So please, Dr. Cristiane and Maria Jose, if you want to make any comments, please, after Dr. Peter, you can speak. Thank you very much.
Thank you very much for these important questions, and it was really exciting also to hear the two short presentations on the situation in Brazil. It's really impressive to see what is already happening in Brazil, and known Brazil as a source of very important research on many nutrition issues. It's also very nice to see that so much is happening on the ground. Regarding the three questions, the first question of how local communities can be empowered to take action on nutrition, I think education is really important in this regard to provide individual patients, but also groups, community groups with knowledge, with skills on nutrition regarding the nutritional value of different foods, but also the social determinants of nutrition, and to raise their awareness of what factors influence nutrition. Personally, I've worked as a primary care physician for several years, and whenever I was asked by patients what they can do to have a better diet, I've advised them regarding the individual diet, but I've also mentioned all the social influences on nutrition to incentivize them to take also social and political action. The second question regarding the need for nutritionists, I couldn't agree more. Obviously, we need multi-professional teams, which should ideally also include nutritionists or dietitians, which are the best experts for these issues. For example, myself as a medical doctor, I've received only a very basic training in nutrition and not at all comparable to the nutrition training of full nutrition professionals. And this also relates to the third question regarding the dominant biomedical or medical model, which is of course also often focused on medical doctors and on more technical interventions. I think here it is also really important to stress the importance of interprofessional, multi-professional work, and also of social medicine and the social determinants of health, and to emphasize this this holistic model of health and disease. So, thank you very much.
Muito obrigada, Dr. Peter, pelas suas respostas. Maria José.
Thank you very much for your answer. Maria José, Cristiane, would you like to comment something? I would like to say that the key is the multi-local professional team that when works in the local, nobody makes nothing alone. It's like Dr. Peter say, we have the doctor, the nurse, we have a training team, but the professional that knows best along with the others, like we have this self-care support, that's the difference. So we have to invest in this model of attention that we have to strengthen in the primary care. Here in Brazil, we have the extreme situations. So we have to change how to approach our patients. So if it's not that way, this is very serious that bring a lot of disease. We have to have this perspective with a multi-workforce with this shared care.
Cristiane,
Cristiane,
comentário?
would you like to comment something?
José complementou. Tá
No, I
tudo
think that's Maria José said everything. Thank
Pessoal,
you.
muito
So,
obrigada pelas
thank you
excelentes
very
contribuições por
much for your
parte e respostas
contributions, your
dos
debates, your
participantes.
answers
A gente
of
vai
the
ter que encerrar agora
participants.
essa
We are going
mesa, a
to
gente passar
end
para a
this
próxima,
table
por conta do
for
nosso
go
horário,
to the
nosso tempo
next one
curto.
because of the time.
Agradeço
So I'd
imensamente
like
em
to
nome
thank
da Segan,
in
Dr. Peter,
the
Maria
name
José e
of
Cristiane,
Segan
pela
team,
excelente
Dr.
explanação.
Peter, Maria José, Cristiane for their explanations. Thank you very much. Lorena, can I have a minute?
Agora eu preciso passar para a próxima mesa.
Now I have to pass to the next table. I'd like to comment something,
Maria
but
José, pode
that's
fazer,
okay.
desculpa.
Okay, Maria José, you can say what you want, but I think that beside what was said, we have global challenges inside Brazil related to the measure that is related in Brazil, the marketing regulatory system. It's not so good because when an advertisement comes in the television with unhealthy food, we have to fight that. The nutrition in the schools, in the hospitals, because we know we know how works nutrition, the hospitals and schools. It's not so good. Drinks with a lot of sugar, that we have guidelines for that, but we need to fiscalize that. How salt are put in food, we still have this problem. And in a general way, we have the attention to the foods for that, for obesity. I'm sorry because I forgot to talk about that. Thank you very
Obrigada a
much.
você de novo
Thank you
por mais essas contribuições.
for
Pela
this
manter esse horário presente.
contribution because
Mas
I
agora
didn't
então
hear
a gente vai
you,
passar para a
but
próxima
now
mesa.
we're going to
Agradecer a
move for the
todos,
next
todas
table.
aqui.
Thank you very much, everyone.
Tchau, Cristiane, Maria José,
Bye,
Peter.
Dr. Peter, Maria José.
Então vamos passar neste momento
Now we are going to move to the next table. So I'd like to invite Mr. Francesco Branco, which is Director of the Department of WHO, to speak about the decade of nutrition 2016-2005, aligned with the global government of nutrition and food. Mr. Francesco, welcome to our seminary. We have 20 minutes. The stage is yours.
Well, thank you very much for the invitation to join you today in this very interesting seminar. Really kudos to the government of Brazil and to the Pan American Health Organization for this meeting. I would like to show you my presentation. So I hope it can be seen clearly. So I would like to start by talking about the value of nutrition in universal health coverage. I mean, you've already discussed the value of nutrition for health, but also the value of the provision of nutrition services for universal health coverage. How can we have universal health coverage without nutrition services? And nutrition services need to be provided across the whole areas of prevention, health promotion, curative, rehabilitative, and palliative care. In order to well integrate nutrition within health systems, we need to consider each of the 6 building blocks of universal health coverage. First of all, the leadership and the governance. So we need to have full integration of nutrition care into the national health sector plans. Second, we need to have an adequate health workforce. As in the previous conversation was mentioned, we need to have qualified nutrition professionals capable to provide nutrition education. And we need to have adequate information for all healthcare workers. Then we need adequate financing. We need to have a costed nutrition care plans and adequate finances. Then we need to have the supplies. We need to have nutrition products included in the list of essential medicines, but also other technological solutions, for example, the diagnostics to enhance access to quality nutrition care. We need to have, of course, adequate delivery of nutrition in health services. We need to provide quality nutrition services with regular monitoring and evaluation. And finally, we need to have the integration of nutrition in health information. So health records needs to include nutrition data. We need to be able to collect data on the population through the health systems. WHO has developed a package of essential nutrition actions. So it's a compendium of nutrition interventions recommended by the WHO. This is already a second edition. We look at cost effectiveness of interventions, and we've included in the essential nutrition action, all interventions that are required to tackle malnutrition in all its form, at all life stages, and in multiple target groups. And I'm just giving you the general concept here. Of course, it's a long document, but it looks at multi-sectoral interventions for healthier populations that also need to act through other sectors, for example, education, trade, agriculture. And then, clearly the set of interventions that need to be delivered through the life course, either for all people or for targeted groups, such as, for example, low birth weight and very low birth weight infants. But protecting, promoting, and supporting breastfeeding is clearly an intervention that needs to be addressed to all. So all different age groups, infant, children, adolescents, adults, the senior people. We include also intervention on nutrition in emergencies. The document provides all information on the WHO recommendation, a summary of the key evidence, the key actions for implementation, and how they contribute to the 6 global nutrition target, and which stage of the primary healthcare function they address. The promotion, the prevention, the rehabilitation, the palliative care. Now, all these interventions are included in the WHO Universal Health Coverage Compendium with all the links to the necessary information. Now, my talk is about the decade of action on nutrition, which spans over these 10 years, 2016, 2025. It was meant to, as a follow-up of the second International Conference of Nutrition, to really accelerate action to achieve the 6 global nutrition targets, plus the nutrition-related non-communicable disease target. The decade of action on nutrition has somehow reorganized the over 60 recommendations of the Second International Conference of Nutrition, and in particular has highlighted how the provision of nutrition actions through health systems is absolutely critical. Of course, as part of the set of actions that need to be implemented to address nutrition. So in food system, in social protection, in trade, in all aspects really of society. But looking at the recommendation on health systems, and I have extracted some, there are a few more, but clearly they highlight the need to address nutrition skills and capacity to achieve this full integration of nutrition action into health systems, to provide that universal access. And then they focus on some interventions which were particularly of interest of the stakeholders of the Second International Conference of Nutrition, and that is the provision of direct nutrition interventions. But what's the reality? After the Second International Conference of Nutrition and the proclamation of a decade, WHO and partners have been analyzing, first of all, the policies and the plans, that governance that countries have put in place to address their health challenges. And as you can see, these are the 6 global nutrition targets, plus some of the targets related to the non-communicable disease. The attention of health plans is very different. And it's certainly not across all the nutrition areas. Clearly, higher income countries have a greater concern about overweight and the nutrition issues related to non-communicable diseases. But for example, they don't focus enough on one of the elements which is clearly critical for all health conditions, and that's exclusive breastfeeding. You see, in upper income countries, only 12% are really addressing exclusive breastfeeding. And vice versa, in low income countries, there's not yet attention to the emergence of non-communicable diseases. So the attention to child overweight, for example, is very low. Only 1 in 5 countries do that. While this is a reality already in low income countries. So you see, the first issue that we have seen is that there's not a clear alignment of the epidemiological situation with health plans. Second problem which we have found is that while certain health services are delivered to certain proportion of the population, the nutrition services, which should be a component of those services, are delivered to an even lower number of people. So, for example, if you look at the pregnant women who have received 4 or more antenatal care visits from a skilled provider, this is still not enough, but it's still 66.6%. So about 2/3 of the women do receive this kind of services, but only 1/3 receives the iron folic acid tablets. Why is that? Children with diarrhea who received oral rehydration solutions, half of them, but only 15% have the preparation that also contains zinc. So this is an issue of quality of services. So nutrition, the nutrition component is neglected. It's not only a question of outreach capacity of health services. It's really a design issue. Third problem, as we heard, it's the nutrition professionals, and we've calculated what is called a density. So how many nutrition professionals per 100,000 population, within a survey that WHO has done in a few years ago, and you can see that it's very variable. What we see in total is a few nutrition professionals per 100,000 population. In the American region, there's a bit more, but unfortunately, this is really more in the high-income countries than in the lower-income countries. And you see in the African region, extremely low, almost zero. Very few nutrition professionals that are able to provide these services. And then if you look at the training, the kind of maternal, infant, and young child nutrition training is not there for all professionals. So even if we have a nutrition professional, it doesn't necessarily mean that professional is capacitated to provide those nutrition services which are critical in maternal, infant, and young children. If you look at the American region, it's about 70%. Some of the training is provided pre-service, but a lot is also provided, on the job and after the entry in force. But still, about 1/3 of the nutrition professionals are not able to provide this kind of services. The next problem is the issue of the spending. And the spending, if you look at, for example, the average government expenditure on direct nutrition interventions, that's less than $2 per person. And then in terms of the investment of donors, it's $1.11. And you see, if you compare with other investment done either by government or by donors, nutrition is always the one which is less resourced. On top of this, the COVID crisis. COVID crisis has disrupted the services across the board. But if you look at nutrition services, and that's the third bar, management of moderate and severe malnutrition, that was used as a sort of a tracer for the nutrition services. 41% of countries indicated that the services have been disrupted, and actually this is one of the highest number. In some cases, it's a complete disruption. In majority of cases, it's a partial disruption, but that certainly means, you know, a big negative impact on the capacity of the services to address malnutrition. And that was March 2021, so already 1 year in the pandemic. Latest assessment indicates that we haven't really done much progress. I mean, this is, again, other tracer indicators, counseling on infant and child feeding, screening for and management of moderate and severe wasting, distribution of vitamin A tablets. You see, very large disruption. More than half of the countries respond to the service indicating we can't cope, we can't deliver those services. But let me maybe tell you some positive stories here. Last year, it was an important year for nutrition with two global summits. One of them was the UN Food System Summit, the other one, the Nutrition for Growth Summit. And in preparation of the Nutrition for Growth Summit that specifically had a work stream on nutrition in health systems, WHO prepared a commitment guide. So it said, you need to act, you know, countries, other stakeholders, you need to act to strengthen these services. And it basically called on action on health service delivery, on health workforce, health system financing, you know, on access to essential nutrition-related health products through the health system, health information system, and leadership and governance for nutrition, giving some very specific suggestions on what could be done. And then the summit took place. It was a successful summit. 66 countries participated, 51 civil society organizations, and they made almost 400 new commitments, which can be seen and can be tracked through the Nutrition Accountability Framework. Donors pledged $27 billion. And the Tokyo Compact of the Global Nutrition for Growth had many endorsements, including WHO. WHO itself made 6 new commitments to accelerate work on nutrition target. Now, what's happened? What happened in response to our calls to action? 67% of the new N4G commitments focused on health, and you know they touched areas on optimal and safe feeding of infants and young children, including nutrition and health sector budget, improving health information systems, promoting access to affordable nutrition products, and reducing marketing of energy-dense foods high in fat, sugar, and salt. So you know, there was a meaningful response to our call to action. And just to mention the names of countries, Kyrgyzstan, Ghana, Honduras, South Sudan, Mongolia, and Nigeria specifically presented their commitment to scale up nutrition within the health system. So something is moving. Another interesting element of hope for the future is around nutrition financing. WHO and World Bank have collaborated on, first of all, analyzing the landscape, and you know, identified a series of potential actions for optimization. And you know, we certainly need to make sure that there is an adequate evidence-based prioritization process to indicate to each country which kind of nutrition services need to be delivered as part of their benefits package. But then the service standard needs to be defined across the health system blocks. Sustainable and predictable financing is critical. And there must be accountability for results and tracking the progress. So there's an interesting document which I really invite you to read, just published January 2022, last month, which, in addition to the analysis, makes some very interesting suggestions on how to optimize revenue raising for nutrition, including also alternative innovative financing mechanisms, what we call more money for nutrition. But then it suggests how to optimize pooling arrangements for nutrition. And often those who deliver services receive money from different work streams, and they don't receive it in an optimized way. So there are some providers or some regions in a country that do not receive the resources they need, and others would receive more. So how do we make that optimization? And finally, optimizing purchasing for nutrition. So how can the allocation of pool funds can be given to different providers? WHO has done some exercise again to provide the costing of the different essential nutrition actions. There's a tool for planning and costing, so all the services are well described, and the cost in terms of supplies and human resources are well indicated. So that should allow clearly good planning when the universal health coverage menu is analyzed, and when governments are looking at how to plan their primary care systems. There is a working group on costing that is continuously updating. Particularly, the case studies are very interesting because countries are very dynamically responding to the challenge of health financing. I think I'd like to stop here by really saying that I hope I demonstrated that we had very clear ambition when we launched a Decade of Action on Nutrition, but we probably didn't have all the necessary tools. But now we have caught up. We have developed all the guidance and all the tools that are useful to make the necessary planning and to make the necessary investment. Political commitment has come, not only through the Decade of Action on Nutrition, but through this Nutrition Summit. And now it's really time to act. I would like to be very optimistic, and I know that with the government of Brazil, I'm really talking to a government that has been extremely capable of leading on the improvement of nutrition. So thank you very much.
Muito obrigada, senhor
Thank you
Francesco.
very much, Mr. Francesco, for the excellent presentation, very rich. And to dialogue about the theme that was brought here in this table, I invite Mr. Miriam Cruz, coordinator from the Intersectorial Chamber of Food and Nutrition from the National Council of Health from Brazil. Miriam, welcome. And for that, I'm going to put a north question for your debate. Miriam, considering that inadequate nutrition and risk is a risk factor that most impact in the global causes of diseases in Brazil, in your vision, in the CM vision, what needs to be done to amplify the reconnaissance and the offer of care in nutrition and food in the APS, which is primary healthcare? You have 15 minutes. I give you the floor. Thank you very much. Good afternoon to you all. First, I would like to thank the invitation done by the General Coordination of Food and Nutrition from the Ministry of Health in name of the National Council of Health. It is a pleasure to participate in an event that is very important like this one for the Brazilian nutrition, and with significant participation debating this theme about food and nutrition in primary health care. It is an honor to participate in these discussions, especially with Dr. Francesco Branca, representative of WHO, so Lorena, but dealing with the theme of the challenge that the event brings for the National Council of Health. Initially, I would like to put here, where do I bring this? Where do I bring my observations, my collocations? Beyond the personal perspective, I would like to bring this place, the National Council of Health, to put the participants to know what is the National Council of Health. So the National Council of Health is a collegiate instance, deliberative. It is permanent from the Unified Health System, integrates the organization of the Ministry of Health. It was created in 1937 with the mission of exercising the social control, that is fiscalization, follow up and monitor the public policies of health within its different areas, taking the demands of the population and to the public power. These current attributions from the CNS are from a great mobilization from society initiated in the 50s through the sanitary reform that profound this discussion about integrality, decentralization, and universality, which came to compose the principles and directories of the unified health system established in the 88 Constitution. The Law 88, known as the Organic Law of Health, points out that health is a fundamental right for the human being, making the state liable to give this health and as a determinant and conditions for food, to health, living, basic sanitation, environment, work, the income, physical activities, transport, leisure, and the access to goods and services, essentials, and amongst others. That is, we recognize the greatest complexity and challenge that has when we talk about health. In the field of the acting for the unified health system, 8080 already highlights that the nutritional and food vigilance and orientation. Long ago, in the discussions, preliminary discussions to the Constitution from SUS, the theme of food and nutrition was already being talked about, especially at the time because of malnutrition, which with the child mortality, which happened a lot in Brazil. So 8080 law of 1990 also creates the intersectorial commissions that are subordinated to the CNS. So the 8080 law already recognizes and expresses the reconnaissance that the National Council of Health, to deal with the dimension of its responsibility, needs to have the support of intersectorial commissions. And one of them is the intersectorial commissions of food and nutrition that already exist since that time. Another important law that was created was the law 8142, which talks about this management of SUS, pointing out beyond the many roles, the performance of conferences, forums, the approval of the budget, health budget that goes through the National Council of Health, the follow-up of its execution, and the follow-up of its execution, evaluating at each 4 years the national plan, national health plan. All of that to guarantee the right to health, the integral right to health, free one of quality according to what was established in the 88 Constitution, be it by establishing to the entire Brazilian population. The National Council of Health is composed by 50% of representatives from the users, 25% of the workers from this health sector, amongst which I am there, once I represent the National Federal Council of Nutritionists, and 25% of the managers from SUS and people that give health services, which were elected at each 3 years. Beyond the Ministry of Health, we also have part of the social movements, governmental and non-governmental institutions, professional entities, scientific communities, and people that give services, in business entities from the area of health. All of this representation is applied to all commissions, including the CIAN. CIAN has the objective of following up the execution of the national policy of food and nutrition, the consolidation of the national vigilance, sanitary vigilance, fiscalization, the implementation of the control of social policies that can reflect on the conditions for food and nutrition of the Brazilian population. It is worth to highlight here in this moment the participation of the coordination of food and nutrition in the ministry, that throughout its history of CNS, answers to the demands of CIAM, presenting its agendas, work agendas, the results of researches, the elaborated materials, among others, other issues, putting always at disposition, putting itself available for social control. We also highlight that the review of the National Public Policy of Food and Nutrition that happened in 2010 came through articulations from the Ministry of Health alongside CIAM. This CIAM shares the attentions given by the National Council of Health to the central issues of health. From 2016, with the approval of the Constitutional Amendment 95, the the Brazilian public branch was frozen until 2086. This a series of policies where fundamental were also altered without the social control. And this is in this moment that I put myself as a representative of the National Council of Health to lament the death of more than 600,000 Brazilians, which were victims of COVID-19 and the bad decisions that were taken to face COVID-19, but also recognizing the fundamental role of workers, from managers, also from the unified health system that in a day-to-day basis act to avoid the severance of the situation. Now, the highlights given by the UN to establish the decade on food and nutrition in 2016 to 2025, talking about the intensification to end with hunger and the malnutrition to everybody, to secure the access to healthy diets and sustainable diets to all people, and the answers for that governments to establish national goals for 2025 and marks based in indicators agreed internationally, brings it a mark for the strengthening of the agenda for food and nutrition as an agenda for the health sector in our country.
Some of the concern could be brought in this primary health care because of the debates that occur in CNS. One of them says about we having global health. By the meanings of the concept, universal access and global coverage. We consider that the emphasis in global coverage in primary care, it's not to limitate the population to have access to it or the offer of access to that because of how they pay. According to technical chamber of CNS, the process of taking out SUS in primary care, it's bringing something to discuss with the possibility of high come profits. So with this analysis in CNS, in primary care in this country that occurred, we highlight the debate was enlarged with social control. About nutrition, what brings attention is the attributes of these tools of the National Plan 2020-2023 related of the time that was made before that was reduced to answer requests of the Economy Ministry. With that change, we observe that the indicators are not showing in the current plan in a way that shows goals, these details, but it's not something that's attached to that. So that was not showed goals that we have to reach through planning. So while we have the national plan that was previous, we had the goal of reduce the consume of drinks, sugar drinks, to only 14% of the population, or to reduce to 42%, to increase the adults that consume fruits and vegetables, or the other goal is contain obesity. Now what we have is only references. The percentage of children between 2 and 10 years that have sugar drinks, we have as a reference 66%, or the percentage of the adults that have fruits, or the percentage of obesity in adults are 82%. So with that, we have an alert to this agenda of the primary care. So we hope that's not true, but we are very concerned in what we see in the document analysis. The problems of the scenario of nutrition in this country brings a lot of problems, because we have to strain and assure the universality and in our communities and its territories. So we have to see how the nutrition is being doing in the country, and then we have to share our perspective, sectorial, intersectorial. We understand that it's a human right, and we have to assure that in the primary health as a resource to look and implement this guidelines. So the educational nutrition is another challenge that was pointed by the National Council of Health. The necessity of the workforce formation has to be doing according with the population needs. So we also want to highlight the population control in all areas and in each unit of health in their territory, and we like to highlight the necessity of the taking back of the health of food council safety. So in the first look, we see that we have guidelines that are according to what we think. So following that, with just a little time, I would like to highlight some position of our council that we bring for CIAN. We have recommendation to the Republic Presidents about taxes in soda and sweet drinks, to forbid sale of drinks. We dislike the national program of scholar food program, and another issues that related to pesticides in Brazil. the defense of food guide, and another question that I have to mention, but I don't have time. So I'd like to thank this opportunity. Thank you very much. Thank you very much, Miriam, for your contributions here to our table for our debate. We have a lot of interaction in our Windows chat, rating, and congratulations. And I'd like to set 3 questions for Mr. Francesco. Mr. Francesco, I'm going to put the 3 questions and then you can answer them. The first question is, the theme of nutrition is prioritized in a weaker way in Latin America? Second question, in which way we can do a comprehensive about resource in nutrition by the decision makers? And the third question, in countries experience, there are countries that are inadequate pattern of countries that are global make for that. So thank you, Mr. Francesco. The stage is yours.
Thank you very much for the question. Can I ask you to repeat the third question, because I didn't quite get it.
Ok.
Sorry.
A primeira, o tema da nutrição.
Only the third one.
Ok, obrigada. Há experiências de
The
países
experience in country that arrive in a level that are adequate universal coverage of essential actions in nutrition. There is something that we could learn with this experience, this successful experience.
Okay, thank you very much. I got it. So first point, you said nutrition is not prioritized in Latin America. I am surprised by this statement. Actually, we're looking at countries in South America as leading many nutrition policies. If you look at, for example, policies to change the food environment by restricting marketing, by clearly empowering consumers to make the right choice with front of the pack nutrition labeling, or also school nutrition. I think these are incredibly important examples which we are using for other parts of the world. Probably what you're saying is that what is done is not enough, and I would agree with you, because unfortunately, despite these policies, still we have not been able to turn down the epidemic of obesity. So we need to do more, and I totally agree with you. But in terms of political choices, I think there are some very interesting choices. We're looking, for example, at programs in Brazil, at the school programs, and how you are connecting the provision of fresh food to what is produced by smallholders. I think that's a very interesting approach. I think the public food procurement idea is becoming a very popular one. There's a school food coalition being established after the UN Food System Summit. But what can we do more? Probably we need to have more than one of these policies. So it's not sufficient to say, okay, now we do only the school policies. We need to do the school policies and the policies to restrict marketing and the policies to inform consumers to make the right choice, and the fiscal policies and the subsidies. So using the financial pressure on food producers. So it's actually a combination, a package of at least 5 or 6 policies. And then we need to provide the nutrition services in the health systems. I mean, we need to have the army of health workers. They need to be the allies of the nutrition movement, and I don't think we have that. Unfortunately, if you look, for example, at promotion, protection, and support of breastfeeding. Unfortunately, the infant formula manufacturers still appeal to the health workers by providing gifts, by providing sponsorship for conferences. And so we lose the alliance of health workers in our nutrition action. So I think that's what I would like to do. And that is a problem, actually. In Latin America, the interference of infant formula companies on health workers is very strong. So maybe if you want a recommendation from me on what could be an important area for action is reducing conflict of interest, particularly in health workers that are dealing with infant and young child feeding. So that's my first answer. The second one is, how can we get more money? That's always the question we have. But I was trying to say in my presentation, it's not only an issue of how much money. It's an issue of how that money is more efficiently used. And I think we need to look at that. When it comes to the new sources of financing, there are definitely innovative ways to do that. I mean, traditionally, the nutrition services are provided either by the government or by philanthropies, but there are innovative ways to do that. For example, what we hear, which is called result-based financing. There are ways to provide services in a more efficient way and to compensate the providers for the services they're giving. So yes, we need more money. How do we get more money? We get more money by, of course, strong political advocacy, by explaining that that money is not an expense, it's an investment. I mean, as you know, for each of those dollars invested in nutrition services, the return for investment is extremely high. It can be 7-10 times according to intervention. So we can do better advocacy for those investments. And the decision makers have to respond to ministries of finances. But we can also make an effort to spend money more efficiently. And then your third question, if I understand correctly, is do we have some good experience from other countries on the provision of nutrition services? We have some interesting experiences, but I don't think we have enough. We have historically, of course, high-income countries have been perhaps investing more in nutrition services. I mean, somehow the primary health care has been using the nutrition as one of the pillars. So countries who have good, efficient primary care services usually have also some good nutrition services. But I must say that I can hardly quote a country that I would say it's a great example. I mean, for some services, perhaps, I think promotion, protection, and support for breastfeeding. Now we have many countries who are using the baby-friendly hospital initiative and they are providing this service to all children. That's good. Iron, folic acid supplementation, and prevention of anemia in women. We're starting to see countries like India, for example, who are more serious in providing the services, also starting from adolescence. So I don't think I can say there's one example. There are some multiple examples, including in Latin America, about provision of health services. But yeah, we're collecting those good examples, and we hope that we can also give some good stories about Brazil.
Muito obrigada, senhor Francesco, pelas
Thank you,
excelentes.
Mr. Francesco, for your excellent answers. They met very well the expectations. Marian, would you like to make a comment?
Bom, eu queria aproveitar.
Well, I would like to take the opportunity, since we spoke also, I was looking at the questions put in the chat, talking about the issues of policies and participation, the need for participation. I would like to take the opportunity to call for the attention of all of you. First, that the councils, health councils can, all of them, be it for municipalities, for the state, they can also institute a intersectoral council for the food and nutrition. What I would like to put here for the Brazilians that were present here, that to mobilize themselves, looking for their councils, health councils. And another issue is that we're in the procedure, we're going to begin the organization of the 17th National Conference of Health. And this is a space to put the agenda, to put the desires, interests, the vision of the social control. That is fundamental, our participation there in this increase of the dialogue with the other sectors of society. And I take the opportunity to invite you all to engage in the discussions and to begin to think that in how they will be able to participate in the next conference. Once more, I thank the opportunity. Thank you very much. We thank you, your presence, for both of your presence, the panelists, and Mr. Francesco, in the name of the Coordination of Food and Nutrition, we thank for your presence. Marvelous lecture. Miriam too, thanks for the partnership. And for us to end this table and this table of discussion, we're going to have an interval of 10 minutes. Then we're going to go back with a table that is called the current context of food and nutrition in the primary healthcare, Latin America and Brazil, and the launch also of publications produced by again the Coordination of Food and Nutrition in Brazil in partnership with Pajo and Abireni. So this is, stay with us after this break, 10 minutes of break, just to take a coffee, walk a little bit, and then we're going to return. Okay, see you a bit.
Thank you very much. Goodbye.
Bye. Tchau, tchau.
A obesidade é uma doença crônica, caracterizada pelo acúmulo de gordura corporal que leva ao aumento de peso. Ela é uma doença multifatorial, então não existe um fator que seja mais importante do que outro para o desenvolvimento da obesidade. Podem envolver questões psicológicas, uso de medicamentos, mau hábito alimentar, sedentarismo. Tem as causas genéticas, pode ter alterações de genes que vão propiciar ou não esse desajuste, fatores hormonais, ou a gente pode ter também os fatores sociais, econômicos. A obesidade ela pode trazer riscos à saúde por si só, pela sobrecarga que ela traz ao organismo, tanto para o sistema ósseo, sistema muscular, sistema digestivo, pâncreas. Ela está diretamente relacionada com o ocasionamento do diabetes, da hipertensão. A obesidade ela não é apenas uma questão de força de vontade, depende do ambiente em que a pessoa está inserida, depende da oferta de alimentos no ambiente em que a pessoa reside ou que ela trabalha. Tudo isso vai impactar tanto nas escolhas quanto no acesso, e são fatores muito mais amplos do que ter vontade ou não. O ambiente obesogênico é aquele que propicia o surgimento da obesidade por atrapalhar as escolhas alimentares e as possibilidades de atividade física. Então, um ambiente em que você não tem nenhum acesso à compra de alimentos saudáveis perto, que você não tem segurança ou calçamento para que a pessoa possa fazer uma atividade física por ali. Muitas das vezes, a dificuldade de acesso vai estar relacionada com o fator econômico. Muitas das vezes o trabalhador ele tem que se deslocar para locais distantes para trabalhar, e quando ele volta, ele não tem acesso a um comércio aberto, ele não tem acesso a uma feira livre.
As políticas públicas do setor saúde são fundamentais para o desenvolvimento de ações em outros setores. Não é possível realizar um enfrentamento da obesidade sem que haja ações intersetoriais. Então, a política pública do setor saúde, ela já deve ser realizada em parceria com outros setores do governo. O enfrentamento da obesidade deve envolver várias frentes, como educação, saúde, agricultura, justiça. A participação da sociedade civil também é muito importante. Então, as políticas públicas, elas podem contribuir de forma intersetorial de várias formas. A partir do incentivo da alimentação adequada e saudável em vários ambientes.
A alimentação escolar, favorecendo que a escola tenha um ambiente mais saudável. Segurança social, permitindo com que a pessoa tenha segurança para fazer atividade física. Esporte e lazer, a pessoa tem um local adequado para fazer uma atividade física. O setor agricultura pode promover a oferta de feiras livres em várias localidades ou em horários alternativos para que as pessoas possam ter escolhas.
Incentivando a agricultura familiar, a agricultura sustentável, o produtor local, alimentos regionais.
Com certeza as políticas públicas elas podem propiciar a prevenção da obesidade a partir do momento que os setores envolvidos eles se responsabilizam pela gravidade dos problemas que a obesidade traz, tirar o foco do indivíduo, da responsabilidade da falta de vontade e trazer para as políticas públicas.
Oi, meu nome é Adriano Salvio, tenho 38 anos, sou DJ e massoterapeuta. Eu e meu irmão mantemos uma horta hidropônica em casa. Optar por alimentos in natura é sempre uma melhor opção para a saúde. Manter uma horta hidropônica é relativamente fácil. Você precisa de um tanque de água, onde você coloca alguns peixes, como carpas. Essas carpas, esses peixes se alimentam. O dejeto deles alimenta essa água que sobe, alimenta as plantas. Não é necessário terras, você utiliza pedras. Dessa forma a planta cresce mais rápido e naturalmente. É possível plantar com pouco espaço sem o uso de agrotóxicos. Eu pedalo bastante, a bicicleta é meu meio de locomoção. A partir daí eu senti uma necessidade de ter uma alimentação mais equilibrada, para aumentar o meu rendimento. Eu opto por fazer meu pão em casa, e dessa forma eu trabalho com produtos mais orgânicos, integrais, sementes, eu preparo da minha forma. Além de DJ, eu sou massoterapeuta. Essa é uma das ações para que eu mantenha uma alimentação saudável. Eu preciso estar bem para poder cuidar do próximo. Para ter uma vida saudável é necessário conciliar uma boa alimentação à atividade física. Convido você a fazer essa mudança no seu dia a dia, trazendo mais qualidade à sua vida.
Olá! Hoje nós vamos preparar 3 tipos de marmitas saudáveis. A primeira, uma marmita tradicional com arroz, feijão ou lentilha, um vegetal e também uma proteína. A segunda, uma versão vegetariana da mesma marmita, trocando a proteína animal por uma proteína vegetal. E a terceira, uma marmita de salada bem colorida e que deve estar presente em todas as nossas refeições. E agora a gente vai conversar um pouquinho sobre o tal prato colorido. Por que comer um prato colorido? Porque as cores dos alimentos estão ligadas às propriedades que eles têm, às vitaminas, aos minerais, aos fitoquímicos presentes. E cada cor presente no seu prato vai trazer uma diversidade que vai te fazer bem. Então, a história do prato colorido não é conversa só para criança, é para adulto também.
Atenção família! Ver os filhos crescerem e se desenvolverem com saúde é o desejo de todos os pais, não é mesmo? E um dos caminhos é a alimentação rica em nutrientes, com alimentos in natura e minimamente processados. Os alimentos ultraprocessados não devem ser oferecidos às crianças. O Guia Alimentar para Crianças Brasileiras menores de 2 anos do Ministério da Saúde pode ajudar com recomendações e informações sobre como alimentar a criança para garantir garantir que ela cresça com saúde. Isso pode evitar problemas como a anemia, que ainda afeta 10% das crianças de nosso país. E para diminuir esse percentual, o governo federal tem a estratégia NutriSUS para fortalecer a promoção da nutrição infantil e do pleno desenvolvimento humano. Mas como isso vai funcionar? As famílias receberão um sachê com micronutrientes em pó para colocar nas refeições dos pequenos de 6 meses a menores de 2 anos. Ou seja, a família tem papel fundamental no processo de prevenção e controle da anemia. E é super fácil. Rasgue o sachê na extremidade indicada e adicione ao alimento já pronto. Como muitas crianças nem sempre comem tudo que está no prato, o ideal é colocá-lo na parte que será servida primeiro. Assim fica garantido o consumo de todo o conteúdo adicionado à comida. O sachê não deve ser colocado em alimentos líquidos ou duros, e nem aquecido. E quando colocado na comida, deve ser ingerido até o prazo de 1 hora. A estratégia é que cada ciclo de suplementação, que ocorrerá a cada 6 meses, a criança vai consumir um sachê por dia até completar 60 sachês. Depois disso, haverá uma pausa de aproximadamente 4 meses, até o início de um novo ciclo de 60 dias. Assim, a administração dos micronutrientes acontece em 3 momentos, aos 6, 12 e 18 meses da criança. É importante que a família retorne à unidade de saúde dentro do prazo para cada entrega e garantir a eficácia da prevenção. E lembre-se, qualquer dúvida, procure sua unidade de saúde. NutriSUS, Ministério da Saúde, Governo Federal.
Ótimo. Bem-vindo de volta.
Welcome again. Let's begin our program with the second seminar. And let's thank also for people who are following up the chat, the participations. We have more than 1,000 people following up on us. We're very happy for these participations. And we would also like to remember you to contribute for the construction of the second letter from Brasilia. The link our team is putting there in the chat to facilitate the access. And I ask for you all that whenever you can, make your contributions. Now, we're taking back our program. Here, we're going to begin the next table, which is called the current context of food and nutrition in the primary healthcare, Latin America and Brazil. I'm now going to invite Mr. Jonas Gonçalves Garcia, consultant of quality and systems of health from PAHO. Jonas, you're going to have 20 minutes to present about the theme of health services, structure of the system for an efficient action in Americas. Jonas, welcome. I give you the floor.
Muy buenas tardes a todos y todas.
Good afternoon to you all. I celebrate you all. I congratulate you all from the WHO office here in Washington. It is Department of Systems and Health Services. I would like to share with you our perspective in all the efforts highlighted and enforced by the World Health Organization to organize the systems of health is a great component for the strengthening of primary attention to health to guarantee the access to quality services and also in the continuous attention and also to contemplate different priorities of health defined in the national and local level. In this sense, we're going to highlight and reinforce that it seems that I have a little bit of difficulty. Okay, you're going to pass the slides. We're now in 2014 during the second International Conference of Nutrition, which was done by the WHO. We already identified the importance to strengthen systems, health systems overall, to guarantee that these systems in the first level of attention so that it has the capacity to deliver services related to nutrition. This is even more manifested and highlighted in this context of the Decade for Action for Nutrition within this action plan in which they define 6 areas that are not necessarily that need to be aligned or to be worked in a non-articulated area, but it's fundamental that the 6 areas have an articulation for these actions. But the second of the 6 areas which were established talks about the necessity to put here these systems, health systems, so that we can reach the capacity to offer services, essential services related to nutrition, including it is clear in the level of concreteness that is very elevated which are those elements in these health systems that should be in some way be oriented in these efforts in some way with all the actions that have evidently appeared, and we hear from the audio from Mr. Francisco talking about this compendium of actions and they are affected for the prevention and dealing of subnutrition, and this there's a very defined with a coverage, a continuous coverage during the entire life, and also oriented for the production and dealing diseases that can be prevent and treat diseases that can be aggravated by undernutrition, but not only undernutrition, malnutrition, but also all the health problems related to overweight and obesity. In this morning, we heard data that reflect about the impact that this has in this society and also about the control of these diseases that are associated with habits that are not healthy related with food, nutrition. This takes into consideration that here the necessity to integrate this in all health levels, of course, with in particular focus in the first level of attention. They were also highlighted to have these health professionals with the great competence and trained adequately so that they can provide the services, and also that we need to have the availability of these teams and also for those medical instruments so that we can take it forward, this work project. In the Americas, the concept of universal health in 2014 was defined in a clear way and amplified with the definition of which is very important for this context. It has to do with the universal coverage of health, and this says that any community, each group can have access to quality services without it being exposed to these risks, and see how these different concepts of access and coverage. With the access, we understand that this capacity so that people can access the health services which are appropriate, comprehensive, and when they're necessary. And this means that these barriers or access are diminished. It could be about the geographical, economic, social, cultural, and including organizational. If there is no organization that is adequate for the health system that has these great resources to offer this care for nutrition, although we have a great definition of that about the access to health, even though we have this type of coverage, if this is not implemented, citizens will find here an access barrier to find this universal health. So this means that we are going to give a follow-up to these services of all this type of barriers to surpass all these barriers so that people and communities can have access to these services, health services. But if you're going to have the sanitary system and resources, necessary resources to take forward precisely these services that meet the necessities of the population, we are going to have fundamental problems in the coverage. That's why we need to deal with the access barriers from the population and also the elements of coverage related to the resources, necessary resources for the system. That is why the coverage of health, universal health, is understood as an availability from these systems and health services of those mechanisms of organization and financing that are sufficient to cover these necessities in all the access and coverage which are fundamental so that we can advance in this concept of universal health. In the context of our region, we have in its center, in its core, the values of understanding of this as the understanding of equity and taking into consideration the people, the communities which are considered its center, the center of this model of attention. This is fundamental for these health models. One care that operates in integrated networks of health in the first level of attention to primary health, and also strengthen that has the objectivity of meeting the priorities of local priorities or defined by the authorities, which contemplate aspects like health, maternal health, non-transmissible diseases, mental health, and this is very fundamental that to generate this consciousness. Another thing that has to do with the interventions to improve the situation of nutrition and everything related to lifestyle and diets. From our scope of technical cooperation, we have defined in 2014 with all the member states a compromise of advancement in 3 lines of action that walk in parallel and symbiotic way. The first one has to do with expanding access to health services. It has to do with actions to diminish these barriers that the population has to access these levels of health, be it of better quality. The second one is about the strengthening stewardship and governance of the authorities, and also has to do with the units and the centers of primary attention, the hospitals, and the joint of the network has the capacity to do the management of the organization to meet the necessities. This was also highlighted in now we see a very important question. How do we finance this? We need to clearly make some strategic decisions to increase the financing from health, not only increase it, but have a adequate usage of these resources. And lastly, an intersectorial action in many aspects within nutrition, taking into consideration the health styles. This is very evident as an action that is intersectoral is very important to generate this empowerment of the population and the community that can understand which are the lifestyles and diets, be it those who are more adequate, to build a health state of well-being when establishing these 4 lines. And then finally, in the issue of nutrition, this will present results from adequate health states. But obviously, before this, there needs to be intermediate actions that can help us to guarantee that we have, for example, adequate human resources that can act, so that teams are sufficient, that they have these elements, information that make it possible for them to do this monitoring of the nutritional state of the population to be able to solve this case punctually. So this also affects the joint of networks from health systems, but without a doubt, with an emphasis posed on the capacities of the first level of attention, because in the first level of attention, where the community and people have this access more direct when integrated, with the resources and where we can integrate the actions, clinical actions, but also the health actions in a more efficient way. I insist here, not in an isolated way, but in a context ethical of coordinated work with a joint of service networks, but as it was highlighted by the other lectures that were before me. Well, I get here into the detail that in a brief way, I'm not going to load you with information. I would like to talk a bit about the objectives which are associated by each one of these lines of action and how we can somehow present actions that can be sustained in such a way that they make it possible for us to advance the access to health and universal health, that it integrates as a right and a component that is central and fundamental. One of the objectives for the diminishing of these access barriers has to do with the action of fragmenting, which most of the time occurs in programs that are centered in the situations of health and the duplication of the services. Because of this fragmentation, it makes it possible to develop barriers, access barriers. That is why it is important that a follow-up is given for the models, adequate models for the local countries, and that resources are put there for these models that integrate actions of all priorities that were defined within this context, so that they can be articulated with more actors, of health actors. Without a doubt, with this investment that we're having here, this, if it was very prioritized, will strengthen the capacity to solve, implement, and of these models. That is why, logically, with the sensibility for diversity, fundamentally for the conditions that make it possible for this vulnerability in people, participating, making it possible for them to know of the procedures of taking decisions, of decision makers, decision making, and the collective construction with the representatives, community representatives, of the best, of those who should be the best models of follow-up. In relation to the strengthening stewardship and governance, this is a fact that many countries in the region present fragilities in the health authorities, especially in some components, and in some of these spaces, it is an opportunity to establish fundamental elections and a policy that integrates these efforts. Like the case for nutrition, it is a gain in which we generated capacities so that we can assure the functions and the exercise of these health functions, public health functions, and beyond that, generate paths that make it possible for the institutionalization of actions integrated overall in this first level of attention when it is strengthened. In a similar way, in relation to financing, a very difficult thing to be answered, when we increase the financing in many ways, there is something that is very evident that has to do with the public expenditure in a better work, in a political level, with data about this expenditure, how it is divided. Having said that, this investment is a gain for society to increase this fiscal space for the public space. Beyond that, to look for ways to spend better in efficiency in this expenditure, especially in the buying process. It's good to remember the necessity for a particular acting in the first level in such a way that others do not absorb a greater level many of these resources in relation to the intersectorial coordination. The role of these health organizations is to coordinate and leader and to be able to make it possible for these to advance in the agenda, health agenda, integral health agenda. So this is fundamental. In the case for nutrition, this is also a paradigm case. I share with you this message, which is very recent, and we are giving all the support, and it has to do with anything that has to do with nutrition, a healthy diet, and we need to here establish a defense for these health systems, in particular through the first level of attention, primary attention, as a principle, as a main element for this that we're talking about, working jointly with those who take decisions, the decision makers in a level of management of the services, health services in the level of the managers, local managers, and also the authorities, local authorities, reinforcing municipal ones, and also to strengthen the human resources that can go through these services and integrate it. Also, facilitating and having spaces to work and participation from the community in terms of co-responsibility of health diets also. I believe that within this simple roadmap that I present here, that we have a path to improve and advance in the access to services related to like adequate nutrition. And I believe that without a doubt, we're going to advance in the establishment of groups, projects and more groups that are each time there is a symbiosis, let's say a synergy, between the specialist in intuition and be it between the works from health services to be an opportunity that is very big. We are here seeing that from the perspective that we see that the situation is being established, and we observe that it is an opportunity that we have, and we need to follow up and strengthen it. There is a duty to see which are, make this analysis of these opportunities that are appearing, there are established priorities in a regional perspective, sub-regional perspective, national one, or local one, for that, so that we can finally be able to achieve our objective, final objective, that is to be remission and the improvement of these health services with an inclusion that is more central to nutrition services. Thank you very much.
Nós que agradecemos, senhor Jonas,
We that thank you, Mr. Jonas,
pela excelente fala, pela excelente
for the
fala.
excellent speech. So now continue this table. I invite Ms. Renata Maria de Oliveira Costa, nurse, is a doctor in public health with workforce management, and also the director of family health of the primary care secretary of a health ministry. Good afternoon, Renata. Welcome. Can you hear me? Yes. So I would like to thank this invitation. Very glad to be here with you. We have a lot of people participating. Brazilians like us are very welcome, enjoy. And I would like to thank the invitation from my department colleague, that Dr. Juliana, which our host here in this event, and a partner in the primary care section. I'm going to share my presentation.
Tá dando erro de código. Será que é porque não está disponível para...
I have a technical problem here. I think it's not available for me to share. Lorena, can you see that? Vinicius, can you help us with that? It's fine. Can you try again, Renata?
Ainda não.
No.
Tá dando erro aqui.
It's an error on my screen.
Não sei qual o motivo. Mas eu já...
I don't know the reason, but I'm going to start.
Apresentação por causa do horário, né?
I'm going to start because of the time. If you can share your presentation with Gisele.
Fazer isso.
Okay.
Mais fácil.
Mas iniciando, né, primeiro...
But beginning first,
que falar de atenção
I would like to speak about primary care, like in Brazil, with its extension.
Com 5.000
is we have more than 5,000 municipalities, and these are organized in 5 regions and 26 units and 1 federal district. It's a big challenge, but I was thinking before seeing the previous presentation that is more difficult to management is to keep my weight and keep my diet. Renata, I said hi to you. If you can send me your presentation, we can work on this problem. Okay, I'll share with you. Thank you.
Mas nós temos avançado.
But we are moving forward.
Mas nós temos avançado muito no que diz respeito à atenção primária.
In the primary health care. So,
vamos agora na apresentação. Facilita.
A gente só está tentando receber a
we are
apresentação.
trying to receive the presentation. We are going to continue in a minute. Okay, Gisele.
Mas aí eu vou continuar enquanto você.
So I'm going to continue while you're working on that. So today
Somos uma rede, né?
we are network, which is very wide, with a lot of segments, with a diversity of action that I'm going to show you. But as I said about the management difficulty in a global way and how we have a diversity country with this theme, nutrition, because our country have a singularity of habits from food, include cultural aspects. But the network of primary health care needs to be qualified to this, respecting this culture question, to insert health habits of nutrition, and this is from actions of promotion of health, and we have some specific health, including the school area, also as the adult area. We are more than 200 million people, and it's a big challenge. We have a wide network, but it still is a big challenge for us to be organized to promote these actions. And more difficult in the hospital care, we work in the nutrition area with a menu that's previously prepared in her daily basis. So it's a big challenge for the workforce. So you can pass this slide. So you can pass the slide. So the first slide that I will talk about is to show the dimension of the country. So this is a big challenge, which is to develop this promotion of health, including the nutrition issues. A while ago, we went out of a different department inside the Secretary of Primary Care that was about a different department. In 2019, we are a very new secretary that have been created. So we're facing this challenge. Now we have these three departments that you can observe on the slide. I'm the director of the family health care. We have 18 coordinations and 5 general coordinations, 2 specific coordination, 1 very informal. We have the program actions and strategy department that have 2 coordinations, and we have the promotion of the health care department that have 3 general coordinations, including us. So I'm going to speak about in a general way how we are organized in a federal level, reminding that this management of health in Brazil, which is a national system, is with 3 bodies. So this service offer, we have to offer in local and federal ways. So we have to think, as Jonas says, that all the systems are based in the primary health care and could not be different once that is the structure of the department or for all the healthcare systems. So to assure this universal access is a challenge, consider the dimension of our population in our territory. But this access should be in a good opportunity for the patients. Also, the primary care already we have evidence or results that are important. So it's important for the quality of life of the population. And in our case, that we work with the equity, we reinforce that through the secretary, it's relevant, the primary care in the national system of health in Brazil. So some evidences related to these results that we reach through the primary care. We know that when we strengthen the primary care, we have this sustainable and very strong. We have a lot of slides, so I have to be fast because of the time, but I will leave that for the participants. This is a scenery that shows the diversity. So today we have these numbers of our teams. Primary health, we have more than 47,000 of family health teams. We have more than 3,000 teams of primary health care. We have over 27,000 oral health teams. That's very important. we have a lot of different levels. We have oncology for that, and we have the basic attention healthcare for prison and homeless people. We have teams or units that are not just fixed in one place. We have the teams that work in the north region of Brazil, which a very high area. It's a big area with a lot of rivers.
Bem, eu vou passar essas competências.
So I'm going to pass these competences because I want to show some strategies subject. So after the presentation, I can show our competences of our secretary. And all three departments work with that. So we can have primary healthcare more developed. In this slide, we can see the competences. They are distributed between the departments to make the follow-up easier. Renata, just saying that you have 5 minutes to conclude. That's why I'm running fast.
Vamos lá.
Okay, thanks. So you can pass the next slide. So a little bit of the family healthcare department. We have the priority primary healthcare. We have 8 coordinators, 1 for resource that is an innovation in our finance strategy with a different model that inserts the development as a source of financing, general coordination of oral health. It's a coordination that's related to others. It's not only national or with our basic teams, but also the specialized attention or care. The promotion of provision of professional in primary healthcare. We have 2 programs. It's a project that's called Mais Médicos in Brazil. We have a lot of professionals that we make available to this program, more than 1,000 doctors acting on this program. We have a new program of policy to provide doctors in Brazil. So we have a public call in this moment to offer 5,000 working spots. The general coordination of information in primary care that cares of our information that are collected by our teams, which the informations are very important for us to evaluate and plan. And now, each time more with the insert of the development indicator to see how primary care is developing. We have another coordination, which is the assurement of the attributes of primary attention, which for sure is to assure the access and continue to this primary care. So this coordination is related to each state and its support to the management in the states and municipalities, and also make technical documents and how to work in the process alongside with the other department, and make the organization of guidelines and activities, the lines of care, coordination of the prisonal system health in prisonal system, which it's interministerial policy. We have teams of primary health that attend patients on prison. We have another coordination that is the quality assurance of primary care of people who are homeless or people that is Black, gypsy population, indigenous. We have several populations, groups of populations, so we have to think about those populations. And for example, refugees, immigrants. So we are a very big country and we have borders that so we can think about that policy for those kind of people. These specific groups include these work activities that bring risks to their health. For example, fishermen population. It's a specific coordination that has a role which is very important related to the equal subject and make the access assured.
Well, in relation to our programs and actions, I brought here these highlights. First, our system of information from primary attention to health, which is a strategy that has been bringing many benefits, not only for the management, but having the care for us to think about the care in health, taking this population from the invisibility. Now we have a Richard there that has been advancing, registering that has been advancing in the more than 200 million Brazilians in this registry for primary attention. Of 70 million of people, now we are in, after the implementation of Brazil, Define Brazil, with the with more than 150 million of Brazilians which are registered there, which means that our teams are not only being registered here, but possibilitating the access of this population in the primary care. The program Saúde na Hora, which is very important once the basic units of health, they can offer the care due to a functioning in a amplified time to the weekends, night, for example, and most of the time our population, mostly adult one that works, cannot access our units, basic unit health units in the time, normal administrative time. That is why this program makes it possible to amplify the access to many municipalities in the country. And then in the informative ADS, it aims not only to qualify our information and to improve our policies, but also so that it makes it possible for these workers to have the possibility to use this information to organize our services and its work processes. Renata, I ask for you to conclude, okay? Okay, go to the other one. I need to run in order to conclude. So the Doctors for Brazil, which is of the plus doctors, more doctors, the national policy of mouth health in the national policy of infrastructure from the APS, that we also have a financing line for the construction and reform of units and equipment of also from these units. Then we are going to have the compositions. We have different compositions of teams in the primary healthcare, making it possible for us to guarantee within the national territory for it to have many teams that give this assistance to the population. I'll go to the next slide, please. the model of financing, like I have already said before, different types of registry for the population, the development of the reach for indicators about strategic programs also, for example, the ones that we have in the national policy of food and nutrition, the population, and a component that per capita component. The indicators of development, which can we see here how the teams are going, thinking about health of the women, but also the pregnant woman. We have indicators of the child's health and also chronic diseases. Now you can go to the next slide. Okay, there, just to give an attention to the two names there for mental health and drug use, which is here in the primary attention, and the coordination of life cycles, which has these 5 coordinations that take care of the child, adolescents, men, women, and the old people, guaranteeing this. And now you can go to the next slide. Then we're going to go fast here, go to the other slide. These coordinations, they make us the management of strategic policies, specific ones for each group for this life cycles. You can go to the next slide. Here we have some of these actions, and obviously we have particular ones for vigilance, National Program of Immunization, the one for studying here, the National Program of Mouth Health, the food, the nutrition also one, the National Policy of Food and Nutrition. So these are policies that talk about the three coordinations of the Secretariat. Renata, please conclude. Now go for the next one until you reach the last one for me to conclude. These are the actions of the women's health, which also has a transversality in the network. Health of the man that has been increasing, old people, also with many actions from the Department of Actions and strategic the part from the psychosocial attention, which contributes for the mental health issue, alcohol and other drugs also. You can go to the next one, next. And now we're going to be in the DAPRAs taking care of the PSC, the health gym, and this the highlight to these actions that talk about the national policy of food and nutrition beyond the control of chronic diseases like diabetes and hypertension. Obviously that cancer also, you can go to the next one. Next one. Well, in the network, there's no dietitians. I think someone asked for it. I was also looking at the chat. When the primary attention from the change of the financing, we were not able to maintain the financing, specific financing for the support networks from primary attention, which we had, but that also we also have in the network, but we had the financing, specific financing, and now this financing is staying there, but it is for the municipal managers. But we have in the network 10,000, more than 10,000 dietitians in primary attention, which are proposing our making propositions, and we has and have this amplified multi-professional team. So this is a great network, which certainly also needs a lot of effort from us to be qualified and to be amplified also. We have many challenges ahead, but we are partners in the sense of promoting people's health through a feeding and nutrition that is very adequate. That's my speech. Thank you very much, and I'm sorry for passing my time. This is our contact here in the Secretariat from SAPIS. Okay, Renata, thank you very much for your contribution, your data. demonstration from primary attention in Brazil. And continuing our table, I'm going to invite Mr. Gisele Portolini, Coordinator, General Coordinator of Food and Nutrition for the Ministry of Health, to speak about the nutritional attention within primary attention of health in Brazil. Gisele, you have 30 minutes of speech. Welcome. Hello to everybody. It's good to be here again. I would like to, before beginning my speech, to say mainly about the people who are watching us from other countries, that we have a primary attention. We're talking about CONASI, or representative from the state secretariats, or representatives from the municipal secretariats, that we have a primary attention that is, it is the door, the beginning door, let's say. It is the basic attention, basic that is next to people's houses. Now we're not said that we have 47,000 teams of health, families helpful. This is a model defended, like we have many teams of mouth health distributed in the entire territory. 70%, 76% of the Brazilian population has access, is covered by a team of the family health. That's why we have many challenges that we have. And that is why this moment now will make us it possible to reflect and think about new ways to advance in this agenda. You're going to see that I'm going to present many recommendations that we have here for this agenda to happen in the primary attention. We need for it to guarantee a minimal structure and that is adequate for us to be able to have an agenda that is strengthened. So understanding all this context is very important. Beyond that, I think it is important to highlight that we have teams of prison health, we have teams of in the streets to understand, take care about the homeless, and now we have also many people that's but it's very difficult to reach. So we also have this team of primary attention, which is composed by doctors and multi-professional teams supported by the municipalities to organize so that our actions in the primary attention. So it is within this context that the actions for food and nutrition happen in the country, which is where I'm going to talk about now. So in all this network of primary attention, that is also organized in network, because the primary attention in the same territory, same region, we have the equipment from high complexity to medium complexity, with the specialized attention for when individuals need to access this level of attention. So I'm going to get into this food agenda and nutrition agenda, and now we're going to launch 3 documents in the team alongside many universities, partners, have been discussing what else can we do to potentialize this food agenda primary attention for 2 reasons. First, because feeding is a risk factor that most impacts in the diseases of Brazilians. So this is a risk factor that makes people sicker. So primary attention needs to be resolute. It must and needs to solve more than 80% of issues, health issues from the population. And yes, the main health issues from the population happen due to risk factors, food, and also we need to work so that the food actions and nutrition actions are incorporated in the routines of the primary attention teams to promote more health and make the adequate care when this is already clear and this person already has some kind of severe issue. So now I'm going to share my presentation. Well, what I would like to say first, mainly we now have here people from 50 countries here. We'd like to talk about slowly for the translation to be able to help us. But in Brazil, I think that one of the greatest advancements that only needs to be highlighted is that both the health as food, feeding, nutrition are rights guaranteed in our constitution to all Brazilians. The federal constitution is from 1988, and beyond that, the unified health system that was created in 1990. It is a legal mark that creates our health system. It recognizes food as a determinant of health and defines that, yes, it is up to the federal government, states, and municipalities to make and implement policies of nutrition and food to promote and protect the population's health. So in the legal marks, be it from the Constitution or the legal mark from the law that creates our health system, these actions are defined and recognized due to their importance. I don't think it's different from other countries or other municipalities that we see and other states that watches us. Now we live in a situation that is insecurity, food insecurity, and that has been aggravating itself in the last years, and that ends up being repercussion is inadequate feeding, nutrition, and consequently we had many problems related to this inadequate nutrition and this food and nutritional security. So in Brazil, it was already mentioned before by Peter Jonas, Brazilians, like many of the population in the world, has been consuming at each less basic foods and having more ultra-processed foods due to many factors that go beyond individual issues, and this has been impacting severely the chronic diseases. And then it is these conditions that we need the primary attention. Here, just to exemplify and say that in Brazil, I think that we're very proud of an action that is food vigilance, which is an action that helps for a long time in Brazil. One of the main and first attentions that happen, which is having this nutritional attention. So the individuals that get is the basic attention units, individual that is cared by one of these teams that I said before. It has its weight evaluated, its consumption, and if this is registered, we also have, like Arada said, a system of information, national information, in which it is possible to know this information, and then from this information we can know of the number of people which were cared by the primary attention, which had their nutritional state evaluated, and the percentage, the overweight, malnutrition. So this is very important because it makes it possible for us, while formulating these public policies to make it possible in municipal level and state level. The management here is done in a tripartite way to identify who are these children, these pregnant women that somehow have a condition that is associated to inadequate food, nutrition.
So we have in the system the name, we have access to the name, to the telephone, so we can seek of this person to offer actions of primary care. So beyond that, in Brazil, we have to focus on the presentation of our specific actions for primary attentions. But I'd like to highlight that the policy of nutrition has 20 years, and it has as a goal to improve the health condition and the nutrition condition of Brazilian population, and propose the actions, nutrition actions on our healthcare that includes the primary healthcare. So we have guidelines that also highlight our policy for primary care that have food and nutrition as highlighted in that. So before I enter in the primary attention, this policy celebrates 20 years. So we made a series of debates with several partners in several cities with professionals and students to discuss our advances and our challenges of this policy, which is a policy for the health system beyond this 20 years. So we have two materials, two notebooks with a newspaper. We have a series of articles that make this analysis of the nutrition policies in Brazil. And last year, we made some debates that are available in the PAHO site about some themes related to nutrition. So this agreement is registered with some advances and some challenges for this department in the national health system. So consider that the primary healthcare is the door of entrance of the patients. We like to say that 7 between 10 Brazilians that enter in the primary healthcare show malnutrition. So I'm going to present to you today, it's a recommendation, it's another effort for coordination to support this 47,000 teams to organize the care to this people that are in these teams, and shows inadequate nutrition or insecurity food. Which are the main strategies that we use to make the agenda in the municipalities? Because the teams are in the municipalities. We have more than 5,000 municipalities in Brazil. So we use repass in our budget to make some action. So we see the indicators mainly related to the nutrition state, evaluating the primary care, consume markers. We have a lot of technical materials that are published, and so we have a lot of paper that helps these teams. We have some training courses that are for free, including specializing training and courses. And we have a strategy to make a network with partners entity in the states to support in this process of implementing local areas. So we have several partners in the city that support us when we do the materials, also to support the states and municipalities implement these agendas. So there's the main tools we have. All this history for the advance of nutrition, the 20 years of PNN, our agenda of primary care, are registered in this article. And this article speaks about the development of this action through 20 years, which is published in PNN supplement, and highlight some advances and several challenges also. So to say that today we are not going to talk about every action, but I like to highlight the surveillance that we have in the nutrition. In 2019, we have over 30 million people evaluating the primary care. Is more than a lot of country. So we evaluate a lot of population. So we can follow up this. We have a big agenda to promote the health, nutrition, several programs include this health, nutrition in school, in breastfeeding, the traditional that most of country has to prevent the foods. We have 3 million kids that have to supplement vitamin A. So we have these cities that we are trying to make more health with the health system. So all this history are registered in this article and has been debated in a lot of spaces. So today I will take my final minutes to speak about these 2 new documents. There is another effort of our coordination of nutritional With partners, we are trying to understand the recommendation to strengthen what we need to do. So the action could be a routine of the teams. Consider that 7 between 10 that enter in the primary care present a condition related to that. So we are going to publish a matrix to organize the cares, also with a partnership that not proposed to be a whole model, but it's a matrix that summarizes the mainly actions of nutrition. We have a series of recommendations, universal and specific practices that are being held as we work between the last 20 years. So it's a result of all this growth and debate in nutrition in primary healthcare. So finally, we are launched this material with a website in the BME webpage that consolidates our documents about nutrition. Frequently, we receive doubts and suggestions or complaints. That's very hard to find our material. So now we have this link that make available these materials in the same place to attend this municipalities and states requirements to support the strategies. So I can't see my time. Oriano, can you tell my how long I have? 13 minutes you have. So the recommendation to strengthen the primary care in Brazil, it's made by several women that support us in this making material. It's qualitative and quantitative, and we debate with specialists. So we have a common sense of some resolution. So this is available in the website of the seminary, and everybody can have access to that. So I want to talk about what are the recommendations that are put together by the manager, states and municipalities that we can strengthen the nutrition care. So the recommendations are divided in actions that be strengthened in the primary care and how they can contribute, and the nutrition agenda that could contribute in the primary healthcare. So my idea is to talk about that. It's like a notebook, how we can advance in this agenda. So we have to adequate the workforce for the family healthcare to have enough coverage. We have 76% of coverage in family healthcare. We have to adequate the multi-functional teams. I following the window chat, what people were talking about. As Renata said, we have an increase of these things that you can consult on the website. We have 10,000 dietists in the primary healthcare. So today in SUS, we have 26,000 dietists. Of course, we need to make more higher than these numbers with more professionals. So we have to take care of this nutrition area to promote the make valuable the demands that are being in the sector. So there are things that need to happen for this to be strengthened. So to invest in permanent education, nutrition, mainly the minimal team. So we have the doctor, the community agent. The approach for the food needs to be shared of the the workers of the work health consider how big this problem is and how we have so many people with nutritional issues. We have to share this care. We have a lot of things that need to be prioritized. Another agenda that we have is to training this workforce, and so they can insert in this formation some nutrition components, some that in the structure is to make available daily basis the nutrition. So in Brazil, we have in the basic units a way to measure the weight, and we have to assure the maintenance of the weight. So we have technology to help us, the internet. Not all of the basic units of health are informatized. We have to promote health in a state and municipality way. We have to make the resource come to the local areas. We have to have resource for the policies of local nutrition actions. Some states have states policies, and this was a recommendation that could contribute to the straightness of these actions, to wide the action of strength healthcare, make that in the level of the councils. Miriam was here today talking about that. Reinforce the care of that in the care lines, making plans, evaluations, and intersectoral policies to promote partner actions between the department, stimulate the approach between the three powers in Brazil to make more available the places to the policies. We can think the intersectoral which points that are make the commercializing products, so we can consider this environment, which is very important. Reorientate the work of nutrition, implements work process that make available to qualify the family attention and primary care. So paying attention in the family health and local health, to implement the protocols of surveillance, nutrition surveillance, as a part of the routine of service of the teams. So we have 90 million Brazilians that was registered that enter in the basic units of health, and they were evaluated. Today we have more than 150 million registered, but because of the pandemic, the coverage decreased. We have to make the organization of the service and the register in the local basis, wide the local analysis and analyze the local registers that we have of their territory.
To incorporate tools that make it possible for the teams to do a mapping of their territory in relation to the tools of commercialization, to the spaces for physical activities, to identify if that territory promotes health or not, and which articulations are possible to be done, foment research, strengthen the participative plans, include indicators for food and nutrition in the indicators which are connected to the financing of the primary attention, have institutional support, promote an intersectorial planning in the actions related to the state nutritional state, implement systems of information and health integrated and that communicate themselves. This is also a challenge that we have here in our country. To improve and strengthen the interface, Renata said that we have a system for primary attention that is in most basic units of health. And once the professional does the registry of the weight and puts the consumption markers, this data is consolidated in a national level, and it goes through a system that we have, which is a vigilance, food and nutritional vigilance system. In this system, the main manager can create a report on how is the nutritional state of its population to make it possible to think about public policies from that reality. We have the challenge to amplify the performance of these events, and related to that, to make the integration and quality for the migration of this. So these are the recommendations that they arose from this study. We're going to comment about this more later. That makes it clear that we have all demands. Juliana read the 2008 letter, and we remember that how many of these demands are still our demands added to new demands, telemedicine, other tools, which we now have. So there are many challenges that we need to surpass in order to advance in this nutritional agenda in primary healthcare in Brazil. I believe that this is the recommendations that can be useful to other countries that also have primary care systems. So just to finalize, we are making it possible to have here, we performed this matrix with Kelly's support and many other women that worked with them, which is a matrix to organize the care and food and nutrition and primary attention, understanding the matrix as a source, a joint organized and systematized of food that aims to solve a problem. So talking about this, it has in which we talk about a brief context of food and nutrition. We do the relation of the attributes, the essential ones, and derived from this, and the agenda. While this agenda of food and nutrition, it contributes so that these attributes for primary attention are guaranteed. The step-by-step on how I do this organization for primary attention to nutritional attention, and the introduction about the practice for care in chapter 5, which is the matrix, which are recommendations of practices for care and nutrition. This brings recommendations, universal ones, and specific ones for the life cycle. So the idea is that this is not a manual, remembering about Chris's speech from Conasams, and it's not a manual to be followed at each moment, but it is a material that makes all this construction in Brazil with experiences in municipalities, which made it possible to consolidate a proposition of a food agenda for primary attention that needs and should be adapted to each place. So as a ministry, we have this role to trying to collaborate with the national institution, but we also have states and municipalities. They have an important role in adapting all these moments for their necessities. Well, I'm not going to be able to get into detail about this chapter due to the time, but I want you to remember that we have this. This is our website. In the seminar, in the chapter 13, we talk about the structure, the tutorial acting, the monitoring. The other chapter, we have the introduction. We talk about what is the care, about the environment, about the practice of care, about the nutritional In the 5th chapter, we have another context. We need to prioritize and also to organize an offer of actions that are recommendations for nutrition. These are divided in universal practices, which is pertinent for all of subjects, independent of their cost of life, and also depending of their life cost. We have specific actions for pregnant women. It is a specific one is breastfeeding. So this is a little bit of the distribution of the recommendations. And then I'm not going to be able to get into all of them, just to exemplify here and to finish my presentation. This is the whole of actions that we have, which are actions, recommendations for primary care. And as you can see, these actions, they already happen in municipalities, and this proposal of matrix began from the experience that Brazil has been accumulating with bad experiences and good experiences. This is an essential action to evaluate the nutritional state and consumptions, and this is an essential thing and just to highlight a few and to identify and perform the adequate state about individuals with any chronic diseases, to map areas and groups with the greatest vulnerability, the differences of ways of food security, to know the equipment of the territory, schools, religious institutions. So this is a whole of actions which are essential ones, to know the environment of the territory, identifying facilitators, obstacles to make the adequate food, identify the users so that can have palliative care for the severe cases, to have their preferences there, use the reports from CISVAN as subsides to analyze how is the health situation of that territory, stimulate the consumption, health consumption in the parties there. So we need to promote the inclusive parties of their workers. You use tools for the management of care to create best practices, coordinate nutritional attention alongside other points of the attention network to guarantee integrality and the objectivity of care. Coordinate care of families in risk of food insecurity, consider different therapeutic approach about diagnosis. So these are the lists of recommended actions that, of course, needs to be adapted to the local context and brings many actions and specific debates. For example, people who are vegetarian, nutritional therapy, palliative care. And then we get into an additional part, recommended actions, which are universal, added to the recommendations by life cycle in case the individual is, for example, a pregnant woman, a young child, a person with has 19 years old, an adolescent, adult, and an old person. So these are recommendations to strengthen to incorporate this agenda. So we have also many recommendations to have the people with deficiency, for people who live in the streets, for traditional communities also. And then we have many annexes to support the organization. So the first annex is about all the materials that we have there to support the formation of health professionals. The Annex 2 also is to support the promotion. The Annex 3 talks about materials to support the evaluation, planning, and monitoring of the work process. The Annex 4, it is about the materials on how the team can evaluate the environment. And the Annex 5, the materials to support the actions of vigilance in a territory. And then finishing here, because I already surpassed my time, you already have here a partnership, that all these actions are partnerships with PAHO, the recommendations. In this part here in the window, we have is a page to support the consolidation of the information and to talk with managers about the importance to invest in public policies of food and nutrition, and to offer the greatest offers, which are induced by the Ministry of Health. So in Brazil, we have the states and municipalities. So within this page, you're going to find many videos, podcasts, all the courses that are there. We have many informatics that consolidates the studies about nutrition and primary care healthcare, and I'm going to highlight this evidence map, which is one that we built that consolidates which are the effective interventions within primary healthcare for the malnutrition way. So this is an interactive map in which you can see the intervention and also evaluate the level of trust and the impact of this intervention from primary attention. This is also a tool that will support this manager, health professionals to identify strategies which are more effective. And then now, finally finishing, we would like to have your support for the second letter from Brasilia, because as I said before, we thinking about Francesco Branca from WHO, we have a country that can be set as an example for primary attention, in which we can say many countries for action to one another. And I think Brazil has a lot of potential to be this country that is a reference for this agenda, but the challenges are a lot, and this letter is for you to help us to reflect, consolidate this debate. It is a letter that will point ways for the managers and everybody from this management to concretize the food and primary attention. So that's why I have here Sagan's contact, our email. Thank you very much.
Muito obrigada, Gisele.
Thank you very much, Gisele. Congratulations. Many people are congratulating you, being very happy for the material that were launched. Those who have not seen it, we recommend it to see it because they're very rich. And now to continue this table, I'm going to invite Ms. Ana Laura Brandão, the dietitian, sanitarist, doctor and researcher in public health from the National School of Public Health from Oswaldo Cruz, Rio Cruz, to comment about the theme. Welcome, Laura, to our table or seminar. You have 10 minutes to speak.
Ainda não abriu seu microfone.
Your microphone is not open yet.
Ana Laura, nos escuta?
Can you hear us?
Não estamos te escutando.
We cannot hear you.
Caiu?
I think we lost her connection. So the presentation is done by her? No, it is through here.
Vamos aguardar só minutinho.
Let's just wait a few seconds. We're going to talk to her.
Ana Laura voltou?
Did Ana Laura come back?
Então, para a gente não perder tempo,
so for us to not waste time,
abrir para o chat, né?
After this table, we're going to open the questions so we can go forward and make the Jonas question. Can you not share the presentation until she came back? Oh, I think she's back.
Então, vamos continuar com a Ana Laura, então.
So let's continue with Ms. Ana Laura. Can you hear us?
Seu vídeo.
We are just seeing your video.
Agora vocês me escutam?
Now, can you hear me? Yes, we can.
Tá dando um microfoninho para eu entrar.
But we can hear echo. So I'm going to enter in the cell phone.
Vocês conseguem me ver, não?
Can you see me?
Ainda não estou vendo. Só
No, not yet. Just the audio.
Tinha uma mensagem de que
We have a
mutaram.
message that we are on mute. I think we can present a video.
Seu áudio também tá ok.
Seu áudio tá ok.
Tá bom,
Your
tá ótimo.
audio is okay. So I'm going to stay like this. So first I would like to thank everyone that is here today, not only the event, but the partners. I would like to congratulate Sidan and all the team and all the work who is being developed. So can you pass the slide? Okay, one more. So as a question that we have some reflection that how the recommendation can dialogue with the reality and contribute to advance the nutrition in the primary care in Brazil. I think that one of the questions is why we need these recommendations. We speak about to amplify the access of the primary care between the years, but with the challenge to qualify this care that's offered by the teams in a daily basis in the territories. So we really advance in the volume, making documents in the last 3 decades. We have this important role to present the responsibility of the nutrition in our country. We advance in some measure with the structure and framework, but we still have the necessity to advance related to the work process, and beyond that we are in a situation that we have a multiple charge of malnutrition. So I'm going to speak about the detail of the recommendation. Our intention is that we have the reality. That's why we can observe when we build this recommendation, how we chose the method, how we seek the common sense in Delphi. We heard a lot of the stakeholders who were interested in the primary care. So since the professional of assistance, the frontline force in the daily base management, the nutrition and the primary care entities, academy in all 5 regions of the country. So that was the idea, bring recommendation that picture the reality. The methodology, as I said, was developed through 2 rounds where we have more than 700 questions with these participants, more than 300 suggestions and recommendations. So all of that were summarized, analyzed, make the category analysis. So we have a second round and we validate that like Gisele presented to us. So the recommendations could involve different actors. That's the big question, how we can involve all these actors in the process of the nutrition actions. So we are speaking for whom is this recommendation? Workforce, the management in the primary care and nutrition, representatives of the civil societies, representative of the professional, researchers and professors. So we can mobilize actions. I think that the recommendations can conduct to mobilize the actions. I think that when we think about the possible ways of this recommendation use, the elaboration of the material is very rich, but most important is how we use that. So how we can make the management evaluate in a participative way. In the primary care, nutrition is very important and urgent, and it's very necessary to build autonomy and protagonism of the group, the degree of responsibility of the teams, which should be responsibilized for the work, and the establishment of make boundaries. So we can see this material in planning, meetings, in primary care, nutrition, to monitoring the actions and activities that are developed, the meeting of the teams, to the perspective of adequate the process and the accountability, what have been done and what have been done. So the recommendation also can widen the synergies.
Sobretudo, né? Principalmente.
Overall, mainly, we can't understand this as something that is give, the primary care and nutrition. And the recommendations point to this necessity of these synergies, not something that we make in law for nothing. Why? We understand that is our governability criteria and responsibilization of these actions, but and I think the recommendation could help the resources and prioritize. I think somebody has the audio not muted.
Ótimo.
Okay, you can go ahead. Prioritize the defense of the primary care model, make it with the family health care strength and the multi-professional actuation and the territory commitment with the local demands, where the people live, where they are attend and take care of. Another important, and of course, the necessity of the presence of the dietitian and the nutrition factor. This was said a lot today with all the professionals that are involved in the recommendation. Another synergy that is urgent is the assistance, because we still notice that our distance, it's a challenge. As Gisele said, the recommendations reassure, go to historical demands at strengths in all the areas of the government, and the necessity of register the information of nutrition surveillance, and also brings a space that's current. At the same time, questions that are urgent, especially for the food assurance and security, intersectory issues. So I think I almost have no time. So one thing that I would like to highlight is the importance of the intersectoriality. Well, so what's that nutrition? When we look to nutrition as a focus of social determinants that are something that we understand it's very complex and is passing through a lot of sectors. It's a mainly reference for the nutrition questions and issues, but the recommendations says this invitation about the intersectionality. So the multi-professional care of that area. So that have to be strength. So in this final slide, I would like to show the faces of people that contribute of the elaboration of the recommendations. Thank you very much. This is my contacts and our interdisciplinary group in Instagram is also here. Thank you very much once more. I don't know why my video wasn't open, but it was important to share these recommendations. Thank you very much. With that, thank you, Ana Laura. It was very good to see this presentation. What's not bad. So we'd like to thank you for this enrichment. We were organized the question, their interactions to finalize the table today. I would like to make a question to Jonas and another to Gisele. So Jonas, how we can incentive a more integrated model of primary care? And Gisele, the protocols of guidelines and workouts, who elaborates these protocols? So please.
Bueno, esa pregunta
This question is not easy. It depends how we see that. It's not about one management in national direction. It's just about the healthcare basis. So it contributes to all the workforce that work with that. With no doubt, it's the shared vision, so it's very clear with a lot of details. So in this sense, I think in the context of singularity, what we have to see what opportunities we have to contribute of integrate these agendas to make this accessible, available. It depends what we are searching for. Thank you.
Sobre os protocolos, como eu pontuei, né?
As I said,
como eu mencionei, né?
As I mentioned, one of the strategies that we make is to count on the university. We have an excellent university and researcher that support us. Things from the epidemiology or for other bodies. We have researchers in universities that support us in the identification of intervention and also how to elaborate materials and tools to elaborate technologies for the workforce of primary healthcare. So I'd like to highlight in the last years, we have several tools to support the workforce. And in the last year, we have make available a tool to the primary healthcare that we are understand that's a thing that's going to support the minimal team in the daily based routine, which are protocols with brief counseling. So with these constant markers, which are positive and negative, and the medical historical, we elaborate this protocol of brief counseling, which is very fast, very brief. As in this case, as Patricia of the University of São Paulo, we have this obesity and hypertension in a partnership with Vivian UNB. So we work with, in a partnership with the university, is something that is demand to the Ministry of Health. Sometimes we receive an interesting proposal that evaluates and shows that that works and should be incorporated in a level of health, public health. So we need to prevent in our guideline the social control and the interaction, considering the evidences that fomented and have support of the university. I think that's it. And the big advances and some positive points that are having nutrition agenda is the support of several sectors in this agenda.
Thank you, Giselle and Jonas, for your great answers. We would ask if Renata and Arala would like to make some comment, another comment. They are here in our table.
Só agradecer mesmo, Lara.
Just to thank for the participation and to wish you a great event and to have a great day. Then tomorrow Master will be here and we continue with to do this promotion and the habilitation of nutrition in our community. Thank you very much. We thank you again, Renata, for your presentation. Ana Laura would like to make a comment. Yes, I would like to incentivize that you all download the material, use it. Makes sense when we use it, when it's incorporated in our practices. So we would like to thank again. I'm very happy to be here and to incentivize you all who are here watching us and later also to download the material, to analyze it. And I think that this is the great important act for us to that it is used. So thank you very much. Thank you, Ana Laura, again. We also would like to thank you all who are here and inform that we were very happy. We had more than 1,500 participations in YouTube here and translated in 3 languages. So it was a great day. So I thank you all your presence here and we wait for you tomorrow in our second day of the seminar in the same platform and also in the same channel in YouTube. Goodbye and have a good night.
Chao.